So I want to start by welcoming a new member. Mr. Joseph Harrington is a seasoned executive with over 3 decades of management and leadership. He brings with him a wealth of knowledge and experience in education, social services, public health, and healthcare. He serves on the board of the Cook County Health and is the co-lead of the Patient Community Advisory Committee of the Chicago Area Patient-Centered Outcomes Research Network, referred to as Capricorn. So now, welcome, Mr. Harrington. So I will turn the meeting over to Dr. Charlove, Elizabeth Charlove, who is the Council Executive Secretary, who will proceed with meeting logistics.
Good morning and welcome. I'll now do a roll call of council members to ensure we have a quorum for today's meeting. Please raise your hand and say present or here when I call your name. Dr. Atkins. Here. Dr. Ayala. Here. Dr. Beckemeyer. Here. Professor Dawes. Here. Dr. Fitzpatrick. Dr. Guillermo Ramos. Here. Mr. Harrington. Present. Dr. Stone. Here. Dr. Wang. Here. And I note that Lieutenant Colonel Gardner is joining us virtually, and Dr. Sullivan was unable to attend. Dr. Zank, we have a quorum for this meeting. I'll now turn to a vote on minutes from the last council meeting. Minutes of the May meeting were made available on the electronic council book for your review. May I have a motion to approve? To approve. Thank you. Second? Thank you. Any discussion? Any opposed? Motion carries. A bit on meeting logistics. Please use the push to talk feature on the microphone in front of you to ensure that everyone can hear you. Additionally, please turn off your microphone when not in use. This is a one-day meeting. As always, a recording of this meeting will be available at the address shown on the slide. Closed session will begin approximately 15 minutes following the end of open session. Next slide, please. Dates for future council meetings are listed on the NINR Council webpage, as well as in the open session materials in the electronic council book. Please add these dates to your calendar. Our next meeting is scheduled for January 28, 2025. This will be an in-person meeting here in Bethesda. I want to remind council members other than ex officio that you are special government employees. As such, you may not engage in lobbying activities while receiving pay from the federal government. Further information regarding conflict of interest and confidentiality requirements are posted in the electronic council book, so please review those if you have not done so already. I will give more specific instructions about conflict of interest and confidentiality at the beginning of the closed session later this afternoon. Now I'll turn it back to Dr. Zank for the NINR Director's Report.
Thank you, Dr. Charlove. So I recently had the opportunity to reflect on the Institute's accomplishments over the last year, and I think they're quite impressive. So, for example, we've had increased interest in our funding opportunities and increased enrollment of individuals from underrepresented groups in our supported science. So we continue to make progress on the goals of our strategic plan, and arguably, more importantly, all of our activities are guided by our mission. So health equity is NINR's North Star, the core value that inspires us and activates us. And we really are working hard every day to ensure that all of our efforts are developed and implemented with health equity in mind. So we've designed today's meeting to reinforce this approach and to start a discussion about where we're going next. So I'm going to spend a little bit of time walking us through today's meeting so we know where we're headed. So after my update, Dr. Guillermo Ramos is going to provide an overview of the recent NACNR report, Ending Unequal Treatment, which revisits its 2003 report on disparities in healthcare. He'll provide us with a general assessment of the most pressing challenges related to health disparities. Then Dr. Courtney Acklin, NINR Deputy Director, will provide an overview of NINR's health equity efforts to date, looking back at our accomplishments over the last several years. She'll also provide some insight into the updated language we're using for our strategic plan's health equity lens, which was developed with the findings of important documents like the unequal treatment report in mind. So this session also includes an NINR investigator and her community partner discussing a project that illustrates our mission in action. So we'll break for lunch, and then after lunch, we'll begin our discussion about how we see NINR responding to the ongoing challenges we face in health equity, and specifically how we believe NINR can continue to lead in this area. So for that discussion, we're joined by two fantastic nurse scientists to share their perspective. Dr. Sean Knight will talk about SDOH and structural interventions, and Dr. Monica McLemore will talk about meaningful community engagement. Now, we believe that both structural interventions and community engagement are essential strategies in the pursuit of health equity, and both represent really important areas where NINR has emerged as a leader. So we've reserved 45 minutes this afternoon for discussion to be led by Dr. Wang. The goal for that time is to hear from council about their big, bold ideas for addressing health equity and how NINR can continue to play a pivotal role in this area of research as we move forward. So one of the key messages of the Ending Unequal Treatment Report is accountability, and what it means to hold people accountable for, if, and how health disparities are addressed. So at the Institute, we believe we absolutely cannot accept the status quo when it comes to health equity or health disparities. And our mission and strategic plan is how we will be held accountable for our action or inaction in the face of this crisis. Nurses especially know the realities of healthcare and how the broader conditions of people's lives strongly shape their health. And if we're not actively contributing to fair and evidence-based solutions, then we are contributing to the problem. So I'm excited to launch our conversation today, which will eventually help to develop our future collective action. So I'm going to begin today, though, with some updates on the Institute, what's going on, some of the great things that are happening since we last met. So we have updates related to how we're advancing science through our funding opportunities, scientific events, publications, and other activities. So let's get started. So I'm pleased to start off by sharing with you something I alluded to a minute ago, that we've updated the descriptions of our 5 research lenses in our strategic plan to provide more guidance to investigators. You may recall that the strategic plan was developed as a living document, enabling the Institute to stay responsive to the dynamic and emerging health issues that our nation faces. And we believe that through this adaptable approach, we can assure that our actions are timely and that they're relevant. The revisions to the lenses reflect scientific advancements, changes in language that we've seen since the plan launched in May of 22, including the NIH Social Determinants of Health Research Coordinating Committee conceptualization of social determinants of health. So it's important to note that these updates build on, but don't fundamentally change the strategic plan. They're just offered to provide additional guidance for investigators in aligning their applications with the strategic plan and applying new science and terminology. So since today's theme is health equity, I'll start with an update on our PAR that we issued in 2022 when we launched our strategic plan. So this funding opportunity, there's one for an R01, one for an R21, called for grant applications that are consistent with the scientific framework detailed in our strategic plan, with a focus on optimizing health and advancing health equity. So this is a unique funding opportunity as it allows investigators to apply for NINR funding on any topic aligned with our strategic plan. So we funded some new R01s since our last meeting, and here are some examples. The first aims to understand how homelessness and its associated traumas disproportionately affect the health of Black women. The second is exploring how to incorporate social determinants of health into chronic musculoskeletal pain interventions. And the third will test a community-based intervention for initiation of antiretroviral therapy and pre-exposure prophylaxis among male HIV testers in Tanzania. So as you can see, under this PIR, we have upcoming receipt dates in October and again in February. So here are some examples of the R21s funded since the May Council through that PIR. The first project is seeking to understand the feasibility of an intervention to provide medically tailored meals to pediatric populations experiencing serious illnesses, in which inequities related to food and nutrition insecurities can affect serious illness outcomes. And the second is a pilot test for an intervention to improve financial and global health outcomes for adolescent and young adult cancer survivors with unmet health-related social needs and financial toxicity in New York City. So we want to congratulate these and other R01 and R21 recipients. We are delighted to support your science that advances the strategic plan. So I want to tell you about a new R01 also funded by our NINR through our Firearm Injury Prevention Strategic Imperative. This study uses a highly collaborative approach to deliver an adapted version of safe firearm program within federally qualified health centers to encourage secure firearm storage. This is an evidence-based program that will be modified using feedback from key constituents and the community. It includes brief counseling with parents and free cable locks. Under the Firearm Strategic Imperative, we've released, just to summarize, 2 training initiatives so far, as well as a research initiative on firearm injury prevention in community healthcare settings. And as you may recall, Council did approve another concept in January on further expanding capacity in this area of research among nurse scientists. So one of the things we hear consistently is that nurse researchers are aware of the critical importance of addressing social determinants of health in their work, but are looking for more opportunities to expand their knowledge and skill set in this area of science. So we've responded in several ways, including an R25, which I'll mention in a minute, as well as our SDOH Summer Research Institute, which we launched this summer. So I think that the event was really an unqualified success. The critical need for training was illustrated yet again when we sent out the request for letters of interest and received over 240 responses. And after a really painstaking selection process, we had an amazing cohort of 16 nurse scholars who participated. This was a diverse group who came from schools across the country and were interested in topics ranging from disparities in heart disease to mass incarceration. The faculty who joined this summer guided our scholars through research design, methodological and conceptual considerations, and the fundamentals of community engaged research, as well as tips for successful grant writing. So I want to thank everyone who participated in this program, the scholars, the faculty, and the NINR staff who helped to plan the event. We're really pleased with the feedback and hope to do more of these events. So I mentioned the R25. So an R25 was released to support short courses as another way we can expand opportunities for SDOH training in the nursing science community. So it's exciting to report that we have funded 5 new R25s, again, with the goal of developing and implementing courses for up to a year for nurse scientists and scientists with aligned interests to help prepare them to conduct rigorous, innovative, solutions-oriented nursing research to address social determinants of health and their systematic maldistribution on health and health equity. So we have now, with this funding, 5 courses in development by teams at Yale, Johns Hopkins, Michigan State, George Washington, and Emory universities. These teams will then recruit scholars broadly, those schools, but much broader across the country to participate in their courses. We had a second receipt date that was this summer, and so we'll share any updates on new awards at a future council meeting. So I was going to pause for discussion, but we might be running a few minutes late. So I'm going to get going, and so we can stick with our agenda. So let's move on to some recent research funding opportunity announcements. NINR issued a notice of intent to publish a funding opportunity announcement that will support research that advances health equity through development, testing, and evaluation of interventions that prevent and address housing instability. The estimated publication date is in October, but we do try to issue these notices to allow potential applicants more time to develop collaborations and to develop responsive projects. In this opportunity, we're interested in applications that focus on SQH interventions that modify housing opportunities, as well as interventions that address housing instability as a social risk by addressing individual and or interpersonal level housing needs. We also continue to sign on to other opportunities with other institutes and centers in areas really that are supportive of our strategic plan. So one example of this is a sign on to a NOC that's been reissued by the NIH Adherence Network through OBSSR. This NOC calls for research grant applications that address adherence to recommended treatment and prevention regimens or maintenance of behaviors to promote positive health outcomes. Applications will be accepted through July 14th of 27. We've also signed on to an announcement with NIMHD, NCI, and others to advance healthcare for older adults from populations that experience health disparities. Now, this initiative will support research designed to gain a better understanding of appropriate screening, diagnostic, and clinical care guidelines in a primary care setting, explore shared decision-making that's needed to enhance care planning and patient agency between clinicians and care teams with the older adult and their caregivers, as well as identify effective strategies for care coordination. So again, that first receipt date is coming up in February. So I'm very pleased to share some of the publications that have come out from NINR-supported scientists since the May Council meeting. These articles include study findings on topics ranging from structural racism and PrEP use and rural primary care for substance use to COVID-19 outcomes and racial bias in pediatric pain perception, as well as a study to test machine learning models for assessing disparities and pregnancy risk. So in more extramural news, I'd like to congratulate one of our NINR-funded investigators for being recognized as one of 3 finalists for the Mitchell Max Award at the 19th Annual NIH Pain Consortium on Advances Pain Research on May 30th. So this is awarded annually to the best poster presentation at the symposium. So K23 awardee, Dr. Kendra Camp, who is an assistant professor at the University of Washington School of Nursing, was an awardee. Her poster focused on a comprehensive self-management intervention for individuals with inflammatory bowel disease. So congratulations to Dr. Camp. So let's turn to our intramural program at NINR. I'd like to share a few updates. So we've added a tenure track investigator who brings expertise in health equity, social determinants of health, and data science to our intramural program. So Dr. Quinn Nguyen joined us just in August. She comes to us from the University of Maryland School of Public Health, where she was an associate professor of epidemiology and biostatistics. Dr. Nguyen is a social epidemiologist who studies contextual and economic factors that contribute to health and health disparities, as well as community-engaged interventions. She uses a range of methodologies in this work, including, but not limited to, natural language processing, convolutional neural networks for image analyses, and question and answer models to analyze a diversity of data sources such as EHRs, administrative records, large-scale social media posts, Google Street View images, and health information provided by the NIH, federal agencies, and hospitals. So please join me in welcoming Dr. Quinn. And then in mid-October, we are looking forward to welcoming another tenure track investigator, Dr. Kirsten Dickens. Dr. Dickens is currently an assistant professor at Rush University College of Nursing. Dr. Dickens brings expertise in community-engaged intervention research. Her research focuses on closing the gap in preventable biopsychosocial health disparities for persons facing disproportionate and intersectional social disadvantage. Most of her research aims to prevent health consequences of psychological trauma among women experiencing homelessness and justice-impacted women in correctional settings. So an early welcome to Dr. Dickens. And then we'd like to congratulate Dr. Leo Saligan, who is an investigator, tenured investigator in the intramural program. His work was featured in a recent international bibliometric analysis paper by Lee and colleagues that included over 2,500 studies from 70 countries. Dr. Saligan has published the third most papers on the topic of cancer-related fatigue, and his 2015 review is the 10th most cited paper on that topic. So congratulations to Dr. Saligan and his team. Our last intramural update, our summer intern, Amara Chukwu Uzandu, was featured on NIH's I Am Intramural blog about the summer poster days. About 800 intramural summer interns participated in this year's program, and Amara was one of 5 selected to be featured in the post. Her poster described her work on a pilot study in Dr. Saligan's lab for using the characteristics of a person's voice to assess frailty in older adults. This pilot study was supported by NINR as part of a partnership that we've talked about developing, or that we've talked about in council that we're developing with several universities in Southeast Virginia. So Amara is currently a rising senior at Hampton University, where she's majoring in nursing and helping researchers develop strategies for improving the safety and mental health of Black women in the surrounding community. She said she chose to work with Dr. Saligan because he's both a nurse as well as a graduate of Hampton University. All right, so I want to talk a bit about Improve. I'm going to try to go a little faster given that, we got the late start. So a lot's been happening with Improve. Thanks to additional support from Congress this year, Improve was able to fund 2 additional centers of excellence. One's at the University of Pittsburgh, one's at the University of Illinois, Chicago. They joined 10 other centers across the country and 2 hubs. Their focus, again, is partnering with communities to design and implement research projects addressing multi-level factors that can affect pregnancy-related complications and deaths. I also want to mention, actually, one of the interesting projects that's come out of it is, I've lost my notes, but there was a training opportunity on interpersonal violence and supporting training in that area to improve and enhance research. So I think that's another interesting and important development since our last meeting. And then just last week on September 5th, NIH announced the winners of the Connecting the Community for Maternal Health Challenge. So I want to remind you, this was a 3-phase challenge that was open to non-academic, nonprofit organizations based in the United States. So this included advocacy, community, and faith-based nonprofits, with the aim of supporting community organizations and the development, implementation of research projects to improve maternal health outcomes in their communities. So we had over 90 organizations who applied to participate in the challenge, which launched in September of 22. There were 15 winners at phase 1 who received cash prizes. Additional cash prizes of $150,000 were awarded to 9 winners in the second stage. And then in the final stage, 8 groups received additional training and mentorship to implement their plans. The groups conducted the proposed research and reported preliminary results. So approximately $1.5 million in cash prizes was distributed among those final winners. So I want to mention a couple of the winners. So Nurturely of Eugene, Oregon received first place for Caring for the Culture, an infant caring intervention for health equity. So that's a project to test the effect of an infant caring intervention on lactation and postpartum depression among Black parents. Second prize was awarded to Central Jersey Family Health Consortium of North Brunswick, New Jersey. Their project, Can It Happen to Me?, developing a pre-pregnancy maternal morbidity risk algorithm, seeks to develop a data-driven tool to identify maternal risk factors and pregnancy outcomes. And then 6 additional winners, which you can see on the slide, tied for third place. So congratulations to all of them. It was really amazing to have these community organizations move their projects and their vision forward. And then I just want to mention there will be a 5th anniversary meeting for Improve to recognize progress to date and where we're going next. It'll be in Bethesda on October 15th and 16th. Part of that agenda will include talking about where Improve should go next. So we're looking forward to that meeting. And then I want to update on a couple of the council working groups that we've discussed over the last several months. First, I'm really pleased to share that we're ready to launch the working group to advance implications on the rapid developments in data science and artificial intelligence for NINR's research and training initiatives. So we're grateful to Dr. Stone for co-chairing that committee with Dr. Bryan from NINR, Dr. Wang, and Dr. Fitzpatrick. We appreciate your service on that committee as well as the other faculty shown on the slide for their really valuable service to the Institute. And we're looking forward to your recommendations to Council in an upcoming meeting. And I want to update you on the working group on SDOH Common Data Elements. As you may recall, NINR co-chairs the NIH-wide Social Determinants of Health Research Coordinating Committee that involves over 22 institutes, centers, and offices across the NIH. The RCC also really is interested and sees the value in common data elements for social determinants of health. So when I shared our plans to form a working group of council to provide recommendations to us, they were really excited about the possibility of planning that group in a way that its recommendations can be more broadly applicable and relevant across the NIH. So those conversations are continuing about what that might look like, and so I'm hoping to be able to share an update on that soon. So we are always trying to share our work and opportunities through scientific events and outreach, so I'm going to share some updates there. We've hosted 2 director lectures. So again, Dr. Guillermo Ramos joined us in August for a lecture on the Ending Unequal Treatment report. So just as a reminder, NINR contributed funding to support this really important follow-up report. And we're really pleased that Dr. Guillermo Ramos was able to represent the perspective of nursing research as a member of that committee that authored the report. So over 550 people joined us for that in-depth discussion in August, and I'm not going to talk any more about it because I don't want to spoil what's yet to come. So our July director's lecture focused on maternal health and social determinants of health. Again, we had really robust participation. Over 500 people joined us. Dr. Mahasan Mujahid is a professor at the School of Public Health at University of California, Berkeley. So she talked about her research in maternal health, and for either of those lectures, both of those lectures, you can find them on our website. We also hosted a panel at CANS. That session was featured NINR-funded investigators, Dr. Rosa Gonzalez-Garda at Duke University, Dr. Matthew McHugh at University of Pennsylvania, and Dr. Sarah Zanton at Johns Hopkins. So that discussion was focused on providing guidance to attendees on how to maximize the impact of their research through NINR's priorities and research lenses. In addition, program staff met with attendees at that conference, again, to discuss funding opportunities and answer their questions. And then we also had program staff doing additional outreach. Here are some examples since May. At the annual meeting of the Society for Prevention Research, Dr. Libby Bowen and Dr. Dion Godet-Greer collaborated with staff at the Office of Disease Prevention on a poster highlighting NIH's portfolio on food insecurity and health among older adults, and also spoke with conference participants about how their interests might be aligned with NINR's strategic plan and where there's the most need for federal funding. And in July, Dr. Ristina Denrick Roberts gave a virtual presentation on NINR's strategic plan and funding opportunities at APHA's Public Health Nursing Research Committee, their monthly webinar, again, to share more information about opportunities for funding. In our January council meeting, we had a discussion about reaching audiences for funding opportunities and encouraging applications. And I shared in May that we increased our outreach efforts to better promote our NINR-led funding opportunities. And we are really encouraged by the robust interest that we're seeing. So here are some of the recent successes. Views of our funding opportunities on our website have increased by over 150%. Our funding announcement emails are averaging 1,500 clicks per announcement. Participation in technical assistance webinars for our funding opportunities is high, averaging over 500 registrants, nearly 250 live views, and 400 YouTube views per webinar. NINR's director lecture attendance has increased, averaging 925 registrants and nearly 500 live views, with hundreds more viewing the archived recordings. So these efforts resulted in our funding opportunities having the highest number of applications, 4 out of the top 5 in available NINR history going back the last 10 years. I want to tell you a little bit congressional updates. Over the past few months, I've had the opportunity to talk with members of Congress and congressional staff about Improve. On June 10th, I joined the other Improve co-chairs, Dr. Diana Bianchi from NICHD and Dr. Janine Clayton from ORWH in providing an overview to Representative Lauren Underwood on the initiative's current activities and accomplishments. NHLBI Director Dr. Gibbons participated as well. I also joined the Improve co-chairs on Friday, July 19th. During one of NIH's weekly virtual lunch and learn congressional staff briefings to educate staff on Improve's current activities and accomplishments. And on May 29th, an NINR-funded project was featured in a congressional staff delegation trip to the Medical College of Wisconsin in Milwaukee. The visit was organized by the staff of Senator Tammy Baldwin, who serves as the chair of the Senate Labor, Health, and Human Services and Education Appropriations Subcommittee. NIH staff selected a study that is testing the efficacy of 2 interventions to improve health outcomes and quality of life among rural older adults living with HIV. So other institutes also had projects highlighted, so we're pleased to share those updates. So I'm going to skip our discussion because we're going to talk a lot later. And I keep talking, so I'm going to try to keep going. So I do want to give you some staff updates from NINR. Really pleased to welcome new staff since our last meeting. Dr. Wynn's arrival earlier, I mentioned. We also had 2 fantastic IT technicians come on board to help with our technical needs. Xavier Gutierrez and Tyler Gutman. Janet Aputu started in July as a health science policy analyst. She'll be working with the Division of Science Policy and Public Liaison. 3 fellows have also joined NINR's team. We have a new fellow, Esther Frederick, from the prestigious American Association for the Advancement of Science, or AAAS program. We also had 2 new fellows join the Division of Intramural Research, Amara, who I mentioned, and Justin Zhao. So welcome to all of our new colleagues. And I'd like to recognize the retirement of one of our longtime members of our intramural division. Dr. Mary Lai retired on August 31st. She had 30 years of federal service, which began at NIH and the Neuroscience Nurse Internship Program. She worked for 20 years caring for patients in neurology and behavioral health. She brought these skills to NINR in 2014, where she first worked as a research nurse specialist. And most recently, Mary worked as the division's clinical operations manager. Mary was a terrific colleague and mentor to so many who came through our intramural program over the past 10 years. She'll be missed, but on behalf of NINR, I want to congratulate her and wish her all the best as she moves on to all her new adventures. And then just a few NIH HHS updates. I'm sure many of you saw the news that on June 6th, NIH announced the Communities Advancing Research Equity for Health, or CARE for Health initiative. This will invest approximately $30 million over fiscal years 24 and 25 to pilot a national primary care research network. So the new initiative is the vision of our NIH director and seeks to improve access to clinical research to inform medical care, particularly for those communities historically underrepresented in clinical research or underrepresented in healthcare. So I'm also pleased to be serving on the scientific committee for this initiative, and I'm also happy to be representing NIH as well on a cross-HHS primary care research work group led by AHRQ. We're also active in the pilot phase of the new NIH Engagement and Access for Research Active Institutions initiative. This is connecting NIH institutes and centers with institutions that have a documented mission to serve populations underrepresented in the biomedical and behavioral research, have limited NIH funding, and award degrees in STEM and medicine fields. So DESK program directors are supporting faculty from 5 of the 18 institutions selected to participate in the first phase. Charles R. Drew University School of Medicine and Science, Meharry Medical College, Montana State University, Bozeman, University of South Dakota, and Utah State University. So program directors were matched with faculty from each of those institutions. They met, discussed their research aims, and have provided guidance and resources moving forward. So we're very proud to support this program and appreciate the partnerships of the program staff with these researchers. So back in June, the Surgeon General issued a landmark advisory announcing that firearm violence is a public health crisis. We applaud Dr. Murthy for using his platform to bring attention to the devastating impact of this issue on the country, which is, of course, aligned with our strategic imperative on firearm injury prevention. I made it. We made it. I went pretty fast. Okay. So again, I want to acknowledge the amazing work across the Institute in moving all of this science forward. I also want to thank all my colleagues who helped to compile all this information to share with you today. And I want to thank you all for listening and helping us move forward from where we are today. So with that, I'd like to welcome Council Member Dr. Vincent Guillermo-Ramos, who again is going to provide us with an overview of the Ending Unequal Treatment report. So thank you, Dr. Ramos.
So good morning. It's a pleasure to be here. And I'm going to be speaking about the Ending Unequal Treatment report as an individual committee member. At times, I may reference things that are my own ideas, and at times, or most of the time, I'll be speaking on behalf of the committee. And so, thank you very much for this opportunity. Here's the agenda of what we're going to cover. I'm going to start by really running through, sort of what was the scope, what's the charge, what were we asked to do, and then provide an overview of the implications and the findings at a very high level. I'm going to move then to some opportunities specific to nursing science to a lead in ending health inequities. And I think this part is more extrapolating what the report says to our own profession in nursing. And so I look forward to having a conversation about that together with the council. And then at the end, maybe a few moments to reflect on the work of NINR from my point of view, really acknowledging what preceded ending unequal treatment, what has really been the work of the Institute for some time, and then also an invitation to everyone to have a discussion around what are some of the opportunities and sort of setting the stage for our two speakers, our two scientists that are going to be speaking later this afternoon about what they see as opportunities from their vantage point. So with that in mind, let me jump right in and kind of talk about the report. And so the report was developed by an ad hoc committee of the National Academies of Science, Engineering, and Medicine. Our charge was to really examine the current state of racial and ethnic healthcare inequities. And I'm going to, in a couple of minutes, define what I mean specifically by the term inequities, and then also how we made an important distinction between the health system and the healthcare system. And in this case, our charge was to look at the health care system and examine inequities in that system. What's really critical is that we had a particular sort of time interval that we were interested in exploring, 20 years. And so the original report was released in 2003. I think many of us remember that it was a sort of watershed moment. It was met by some communities with a lot of opposition, I would say, a lot of tension, a lot of disagreement, disbelief. And then there were other communities that felt like finally acknowledgement of our experiences. Well, this was asking a fundamental question: what has happened in the 20 years? Have we made progress? Have things stayed the same? If we have made progress, then what exactly has accounted for that progress in terms of policies and programs, in terms of science advances? If we haven't, then how do we start to understand what went wrong and what do we do to move forward? A little more in our statement of task, we were asked, as I mentioned, to examine the major drivers of healthcare inequities. I've mentioned that we explored what was successful and unsuccessful in terms of programmatic and policy interventions. What are the gaps in our current evidence base? What are the areas that we should be, as a nation, exploring so that we can actually strengthen our science in terms of how we respond programmatically and in terms of policy? How do we scale interventions? I think many of us in the room, if not all of us, know that there are many interventions that are terrific that never get scaled. And I would say, this is my comment, that that's particularly true in disciplines like nursing. Nurses contribute lots of important breakthroughs around programs and policies. Wouldn't it be terrific if we could scale those to have a population health effect? And then the last part, but probably the most important, we were really interested as a committee in having a section on accountability. What are the specific actions and actors? What would we do specifically as a nation to address the inequities that remain in our nation? So important to take a moment. I'll just spend maybe 2 or 3 minutes on this, but it's really critical. These are not ideas that are new. And in fact, I could have gone further back, even prior to 1985, but I'm starting in 1985. One of the things that I enjoyed as part of the recent NACM committee was that we were very deliberate about taking a step backwards and really hearing from those that had come before us about what they had done and sort of what the issues were historically. I think most of us will remember that in 1985, there was a report commonly referred to as the Heckler Report because of Margaret Heckler, who was the HHS secretary. And it was the first time in our nation that we had a group of eminent leaders, scientists, scholars, who came together to really explore racial and ethnic, at the time, what were called disparities, and to try to make sense of this. And what was interesting, and this is a very important point, that in 1985, the nation was reporting that life expectancy was at an all-time high. And that was true in aggregate form. But what was also true is that in 1985, the life expectancy for African Americans, as one example, the report has much more in it, but as one example, was that of whites in 1950. There was a 30-year gap between whites and African Americans in 1985. And the question was, well, what do we do and how could we explain this? I don't have time today to talk about what came of this report, but there were many, many important things that came from the Heckler report, including the Office of Minority Health, the elevation of NIMHD from a center to an institute. There were great things that happened. I will also say that in 2003, at the time, what was called the Institute of Medicine, pursued and was interested in the 2003 unequal treatment report. And this report, probably, I would say, these are my words, one of the most significant reports, health policy, that, at least in my lifetime, that I've seen that has really changed my understanding of my role as a nurse scientist, is unequal treatment. This report did in fact reaffirm that what we call today social determinants of health matter. And I'm in no way diminishing social determinants of health. As many know, I'm sort of a big proponent and advocate for that. But what was also true, and this was very clear in the report, that even if we corrected for all of the social determinants as we commonly think of them, that we would still have disparities. At the time in 2003, they were called disparities. And the reason for that was because we had systemic and structural racism in our health and healthcare systems. And so both of those things being important, structural and systemic racism and also social determinants of health. So I think I've set the stage for 2024. And as a committee member, I was so honored and excited because I really wanted to know, did we make progress? And I had a sense of whether or not we did, and probably folks in this room prior to the release of the report did as well. But I wanted an empirical sort of overview of what really happened and did we make progress? So here is a snapshot of the committee. There is an interprofessional committee, really fantastic folks. I'll just mention a few, and in no way am I diminishing those that I don't mention, but just quickly, Georges Benjamin and Jennifer DeVoe were the co-chairs. Many of you will recognize Georges as the CEO of the American Public Health Association. I'll mention John Ianian because of his work on Medicaid. He's sort of a very eminent policy Medicaid scholar. Daryl Gaskins and Thomas Leveist are leaders in terms of the economic arguments for the cost to our nation around inequities. I'll mention Valerie Bloomberg-Jurgen, who really was a strong advocate around indigenous communities, Native American people. Maggie Alegria from Harvard, who is an eminent scholar in mental health, as is Ruth Shim. And then I will end by saying that Francis Amanqua was our study director from the National Academies. Without him, we wouldn't have been able to do the report. He was tremendously important. You can see the sponsors, NIH, including NINR, the Agency for Healthcare Research and Quality, and where there were some additional resources for dissemination. There is an interactive website and a set of resources that take the report and make it more digestible. And so I'll talk about that a little bit later. We started off with an extensive literature review and spent months trying to get conceptually clear on what we mean, terms that maybe sound like all of us would agree, but turns out a lot of smart people can come into a room and disagree for a long time about terms. And so we had to spend time really thinking about what those terms are. We also had the ability to commission very specific papers. We commissioned one paper that really looked at 20 years and policy advancements that either were successful or not successful. And I don't think it's sort of out of line to recognize Professor Dawes, who was the lead in terms of providing that overview. It was a fantastic way of informing the committee. There was also a set of analyses that were done around health inequities by condition, by race, ethnicity, by geography. And so there was a lot in addition to the report that informed the committee's deliberations. Many public workshops. We had some input from the formal nursing profession. One was Dr. Ramey Alexander, who represented the American Nurse Association from UNC, and Ernest Grant, who was the former president of ANA, served as a reviewer, one of the reviewers for the report. And then there was a link that was sort of open to the public and we received comments from many constituencies and often discuss those in our meetings. So in a nutshell, the report is just under 400 pages. It's got a lot of content. And so I think part of what is really refreshing, and you can see from the QR code that's on the screen if you follow that to the website, since the release of the report, there have been a set of materials developed, an interactive website, a video, fact sheets that are for policymakers. There is a framework that really lays out the main conceptual underpinnings of the report. There are many tools, and we continue, or NACM continues to add things to the website. In a nutshell, there are 8 overarching conclusions that really summarize what we found over the past 20 years. There are 5 goals that are sort of aspirational with an eye towards the future. And then there are 17 specific actions that have an actor and a specific recommendation of what should be done. I encourage folks to look at the report. It's organized in the way that's depicted on the screen. And I think there's something for all of us, whether we define ourselves as being sort of directly working within healthcare or nursing science, research, et cetera. There are pieces for every single aspect of our nation. If you can't read the 400 pages, and I know that's a big commitment, there is a number of papers that have come out, and the committee and others are still working feverishly on other manuscripts. One of them is in Health Affairs, which really provides a 3 or 4 page summary of what's in 400 pages. And so I would check it out. The QR code is there. Last week, there was a viewpoint that was released in JAMA that was co-authored by the chairs and by Francis. Again, another great shorter version of what's in the report. So a couple of key definitions, and then I promise I'll get to kind of the take-home message. So I mentioned at the start that sometimes it takes a long time to get clear conceptually what we mean. And so I think our scope and our charge was really looking at the healthcare system. But undeniably, the committee knew and really struggled with recognition that there is a broader health system and that the healthcare system is embedded in that broader health system. And so there will be times where I may mention the health system in my comments, and there are times when I will mention the healthcare system. The healthcare system, as we know, is where the actual services, the health services are provided. It's the organizations, it's the resources, it's the individuals, the workforce that is providing healthcare. The health system is much broader. The healthcare system is shaped by the health system, and the health system independently shapes outcomes. And so very, very important. When I mention health outcomes, I'm really talking about, or the committee is referring to, the health status of individuals and populations. This is a point that was important to the committee, and it's actually important to me. And by no means is it in any way sort of intended to reflect that the use of the term disparities isn't in many sort of sectors completely appropriate. But the committee felt that we needed to move away from the term disparities. And the reason for that is that in our sort of deliberations, we talked about disparities really reflecting a difference in a particular outcome. And for what we saw over the past 20 years, we saw what many of us on the committee, the majority, felt was preventable, it was unjust, and it was unfair. And for that matter, or in that sense, we decided that we were going to adopt the term health inequities and healthcare inequities. And so that will be the terminology that I will use, because they are preventable, they are unjust, and they're unfair. So here in a nutshell is sort of many of the findings I've taken from the report and organized them in a way that I think will help us to kind of understand what's in the 400 pages. So the first thing is that over the past 2 decades, since 2003, that as a nation, there's been limited overall progress in the elimination of healthcare inequities. Okay, so I just want to pause for a second, because that was something that surprised me. I sort of sensed it being a nurse and sort of working in different contexts, but seeing 20 years of data for our nation and really seeing that there had been limited progress, I think that was something that was, in my view, pretty surprising. These inequities, the healthcare and the health inequities, are highly concentrated in racial and ethnic, marginalized and minoritized populations. Okay, highly concentrated. In order to move forward as a nation, there is a strong sentiment that we need to eliminate health and healthcare inequities versus solely advancing health equity. And yes, we recognize that the elimination of health and healthcare inequities is an incremental process, but advancing health equity felt less committal. It felt less about measurable progress and clear goals. And really, the elimination of the health and healthcare inequities means that as a nation, our goal should be to really ensure that we do not have these preventable, unjust, and unfair health outcomes, and that we can do this. And that's a clear sort of benchmark of where we need to go. I've mentioned already that the healthcare system is embedded within a larger health system. That health system directly shapes the healthcare system. The healthcare system is influenced by that larger health system, and that health system directly shapes health outcomes independent of what happens in the healthcare system. This is really, really critical, number 5, and something that I think as a committee we were very proud of. It's probably undeniable. I would imagine that most people in the room wouldn't agree with the fact that we are at a particular sort of social political moment in our country's history. It's probably an understatement for me to say that we have different views on the way that we should advance as a nation. Some of what has been our dominant perspective, or some of where the tension has been in terms of where each of us may stand, is in what is commonly referred to as the zero-sum game. If we make investments in those groups that are furthest from achieving the equitable outcome, from the elimination of the health and healthcare inequities, then somehow that means that another group is losing out. And so if we make investments in indigenous communities, then some other group is missing out. If we target specifically Latino individuals, and another group is losing out. I think folks can appreciate the argument of what I'm saying. Well, what was clear in our review of the evidence was that this zero-sum game is a myth, that it's not true. It is through directly focusing our efforts on the inequities and the elimination of the health and healthcare inequities that actually we see improvements in the status of those groups. But here's the part that was really exciting. And we see benefits to populations outside of those groups. And we see the same is true when we choose as a nation to not address those inequities, that it doesn't only affect those populations that are experiencing the burden of the inequity, but in fact, it has implications for us all. This is a message of why we're in this together and why it matters when we see investments from all of the important institutions in our society, including an NINR, in specific communities. It's not just about that community. Yes, it will benefit them, but it will have important implications for communities far removed from the community that is the immediate recipient of whatever that is that the program or policy is intended to address. We know that we have a healthcare system. This was quite pronounced and robust in the report as well, that overly prioritizes diagnosis, treatment, and management of disease. We have a sick care model in our country that places most of its resources on acute care. One of the things that was apparent in the report was that the smallest investments were made in primary care, in terms of workforce, in terms of actual resources to run primary care, in terms of research to study primary care. We are a model that focuses, a health model that focuses on volume of services, often in the costliest settings with the costliest procedures. And so again, where are all the places that we could do much more work around keeping the population healthy, health promotion, prevention, restoring people to their optimal health, and actually save money while having greater investments in population health. The only kind of healthcare that has the benefit of a population health effect is primary care. And yet it is, as I mentioned, the setting where we make the least investment. The thing that was really interesting also in the report that we spent a lot of time on was really looking at the evidence around the integration of clinical and social care. And what is it exactly that the role of the healthcare system is in moving beyond the traditional domain of clinical care and formally integrating social care? And how do we make our care less clinician-driven, but more person-centered, more whole-person focused, more relationship-based, and that focuses much more on wellness, prevention, and health promotion. And so lots of content about this and lots of questions in terms of nursing science around what does integrated social and clinical care look like. Our workforce is too narrowly defined. We need more people, not just the traditional doctors, nurses, pharmacists, social workers, et cetera, but we need to think about roles that are currently not well defined, and also actors that need to be formally embraced. We need to remove arbitrary and unscientific restrictions on the entire workforce. This is something that is quite pronounced in nursing, but it's not just nursing. It's also pharmacy and physician assistants and other actors. Every single healthcare professional needs to be all hands on deck, and we need to be operating at the highest level of our competencies and our training. We need new people, new ways of doing things, and be organized in interprofessional teams that are working together to address our nation's health. We do not have a representative health care and health workforce. And so the workforce that we have is not able to respond to the needs of the populations that are being served. The strongest evidence that we have around sort of the importance of having a representative workforce really comes from all the literature on concordance between patients and providers. And those mechanisms are not completely understood. There are a number of things that are positive. They're in Chapter 5 of the report. But what is clear is that as a nation, we must have a representative workforce that is representative of the populations that are receiving care. We need to examine critically our workforce in terms of decision-making, the kinds of tools and algorithms. There's lots of interest in technology and AI, et cetera. And those are things that are good. But the challenges that we have, and this is well documented in the report, is that much of that technology is plagued by the same bias that we have in sort of the healthcare workforce as it currently exists in terms of people delivering care. And so we need to be careful about that implicit bias and not replicating that through the use of technology. We don't routinely collect a report. This was surprising to me. It may be that others in the room are aware of this, but I did not know this. We do not routinely collect a report across all sort of, agencies in our nation and all settings, patient data on race, ethnicity, tribal affiliation, language data. And we certainly, this I didn't know, we certainly don't report data that really highlights the inequity. We may make comparisons that are descriptive, and I can give examples during the Q&A, but we very rarely are reporting on inequities. And we don't adequately invest in research that is focused on solutions, and those solutions being tied to the elimination of health and healthcare inequities. It's very important because there have been there's been progress, certainly. I mean, one of the chapters in the report really looks at funding at NIH and shows that there have been increases, significant increases in dollars that are allocated to health equity research. What's also true there, and something that I have been excited to share, is that NINR and NIMHD have been leaders in terms of the allocations of their overall portfolios to addressing this work. But overall, the lion's share of the resources are not focused at any of the institutes at NIH on work that would eliminate health and healthcare inequities. We need to do more, and we can do more. And then the last point that I'll make around sort of high-level findings are that we've had many policies, and Professor Dawes can talk about this when we get into our Q&A. But these policies, boy, was it interesting seeing policies and programs that in fact have helped and that have been successful where there is evidence. And so, for example, things like the Affordable Care Act or Medicaid expansion. And then also policies that have actually not been helpful or have the potential for exacerbating inequities. For example, what we're experiencing now around some of the limitations of the consideration of race in terms of higher education admissions decisions and what that means for the healthcare workforce, given what we know about the importance of representativeness. And so I think I'll stop there in terms of high-level overview, but let me just share, on August 27th, I did have a wonderful invitation by NINR to talk about what this means for nursing science. And so I'm not going to have time today to kind of review all of that, but my lecture was focused on these 6 pieces. And at a very high level, I'll just highlight some of the things I said, but the recording is on the website and it's available for folks to see, and there's lots more specifics around some of the implications. But let me just go through really quickly and highlight some of the areas. So in terms of health and healthcare delivery models, I think I've already mentioned research that really thinks about new ways of moving away from sick care and prioritizing the integration of social and clinical care. Much more of a focus on primary care. It's the backbone of healthcare. How do we enhance the person-centeredness and the whole person perspective in healthcare delivery? How do we think about interventions that are dynamic and that are multi-level and that can effectively mitigate the harmful social determinants of health? These are just some examples. Again, there's more in the lecture. Second area, in terms of evidence generation and methodology, how do we resolve some of the conceptual tensions and close gaps in the empirical evidence? One of the things that has been, concerning to me is that there's a group of scholars who are writing papers, as many of you are aware, that are questioning whether or not it's wise to make investments in social determinants of health, and should health dollars be used within, programs that address social determinants of health. Probably one of the most recent is a report that came out of the Manhattan Institute by a senior fellow who's there, Dr. Chris Pope, who argues that our emphasis on social determinants is inflated, and that we run the risk of spending too much of our resources from health dollars on addressing social determinants of health. So I read Chris's report very carefully. He's just one example. And I feel tremendous gratitude to him. I actually reached out because I think he raises some questions for us, those of us that believe that there should be integration of clinical and social. His questions actually they're like shining the light on how nursing science can lead and how we can actually address some of those gaps. I don't agree with everything he says, but boy, am I happy that he sort of said, hey, there's room here to grow and there's room to actually have our nursing science lead. We need new study designs and methods. We've got to work on measurement and how do we think about measures that specifically quantify and describe the health inequity. Large-scale multi-site demonstrations of novel models, and then implementation science. How do we scale up? How do we sort of have greater impact? In terms of our workforce, enhancing training opportunities for a scientific workforce that is committed to solutions and really to the elimination of health and healthcare inequities. How do we improve the competitive acquisition of funding for the nursing workforce? So this is now part of the application of the findings from the report, sort of my thoughts. But, as nurse scientists, we've got to think about the pipeline. There are clearly issues in terms of retirements, in terms of the numbers of people that are pursuing a PhD in nursing, and also the funding rates of nurse scientists at not only NINR, but also across NIH and other federal funders. We've got to get our nurse scientists sort of funded and make them more competitive, make us more competitive. And then also the issues around the representativeness. Do we have the right workforce? Do we have the right people asking the right questions? And do we have the right kinds of individuals that are representative of the communities that we're seeking to serve, leading that research? In terms of meaningful community engagement, so the report really elevates the community, and I'll just say, and I'm looking forward to hearing Dr. McLemore's talk later this afternoon, but it says pretty clearly that community needs to be elevated to the same place where the healthcare system is. If we are going to eliminate health and healthcare inequities, then we need to think about ways to meaningfully engage communities. There is, kind of a strong shout out for evidence-based frameworks and what is commonly referred to as meaningful community engagement, MCE. It's really important that we incorporate MCE into scientific training and that we are holding healthcare systems accountable for using the data that they collect and they're required to collect on the communities where they're located to do something about what they're seeing in terms of the inequities. I think one of the pieces that is this last point here is that we need leadership from all of our institutions in society to really see that there are these larger issues around centering the elimination of health and healthcare inequities and dealing with how do we make health and healthcare more trustworthy and address societal mistrust of healthcare services. The last point, and then I'll wrap up, is really evidence-based policies and legal payment reform. And just 2 points. I think there are lots of opportunities for nursing science to really look at a whole set of natural experiments, because there are policies that are changing that are really important that we should be following closely and seeing the impact and the effect of these new laws or existing laws, and whether or not these laws are resulting in things that are consequential to our nation's health. And then, all the work around payment reform and really thinking about movement away from a model that over-prioritizes procedures to really a model that emphasizes how we can incentivize health outcomes, but ensuring that when we do that, that we're not doing that in a way that winds up then being sort of unintended consequence. And there are many examples of that we can talk about during our Q&A. Last thing, I thought I was on the last one, but I got one more. And so priority number 6, I think I've mentioned solutions and the importance of solutions and really moving beyond just descriptions and characterizations of inequities. The importance of a clear stand on the elimination of health and healthcare inequities versus a more incremental approach to advance health equity. And then a direct shout out to our nursing schools and our professional organizations to really center the elimination of health and healthcare inequities. That has not been, in my experience, I've been at a number of institutions, the way that nursing education and nursing organizations are currently set up. This is something that we can change, and this is something that we should change. So just in a nutshell, to wrap up, I just want to spend a moment acknowledging NINR. I think Director Zhang did a fantastic job. I know we didn't have a chance to discuss this, but I'll say on behalf of the council, and hopefully you guys won't see me as speaking out of turn, boy, was that impressive, the overview and the report, because it really speaks to what preceded, what really preceded ending unequal treatment is the NINR strategic plan in 2022. You can see from what's here that NINR has been doing this work, and that was something that came out in the report. And there's a special shout out in the report specifically to NINR. Some examples of leadership are all the mechanisms. I won't review these. I think Director Zhang did a great job at talking about these, but there's lots of evidence that NINR is really leading and making serious commitments to eliminating health and healthcare inequities. The Summer Institute was another great example. And so again, I think that was already discussed, but this is something that we all should be proud of, and we should be really making sure that we're sharing and that we're letting people know the important work that nursing science is doing, led by the support from NINR. I'll end by simply saying that we're in this together. We are in a moment, as I mentioned previously, where there's great social and political polarization, and that polarization, it poses a risk that as a nation we won't move forward, and that in 20 more years there'll be somebody else, not Vincent Guillermo Ramos, but whoever is coming after me, will be sitting here saying that they looked at the 2003 and the 2024 and the most recent report, and that we still are a nation with health and healthcare inequities. And so in order for that not to happen, we've got to realize that there is no such thing as the zero-sum game, that is a myth. And that we do need to really focus our efforts on the communities that have the greatest inequities. And in doing so, it benefits all of us. And that we all will benefit if we respond to those inequities. And if we don't, there are consequences for all of us. Thank you very much. And I certainly appreciate the time talking today. There are some resources of things that my group has been writing that may be of interest. And so if there's, there are open access materials, take a look at those. And then I'll simply end by just saying thank you for the opportunity to talk today. Appreciate it.
Thank you so very much, Dr. Guillermo Ramos, for your service on that report. And for your meaningful contributions and leadership. And we appreciate you sharing that today. It really is, I think, for us, reassuring and inspiring to see the alignment between the strategic plan and the report. So we're glad for that. But at the same time, we agree with the conclusions of the committee that there is a lot more to do. And we're committed to generating the science to get there. So I've asked Dr. Beckemeyer and Professor Dawes to open the discussion by sharing your perspectives on opportunities for nursing science to respond to the report. And then we'll open up to everyone to jump in and share your ideas too. So Dr. Beckemeyer, would you like to start?
Okay, so thanks for having me. I loved hearing your overview and seeing your slides ahead of time and getting the chance to sort of dig into this full report. Although I wish I'd have found the Cliff Notes first, but anyway. And I was asked to sort of to reflect on this from my perspective. And so my unique or different perspective, and mine is as a nurse scientist, public health systems researcher. And, thinking from my lens, nurses are the backbone of our public health system. And so thereby we carry a big burden in terms of our obligation around assuring the effectiveness of our prevention system. So that's my lens. I was really excited by so much of this report, and I'll just not reiterate the things you talked about necessarily, but focus on this from my lens in terms of the focus and types of studies and approaches and populations maybe for that jump out to me that we should look at. In terms of the focus, to me, this really sort of screams we've got to be our science and research needs to be at multiple levels, and it talks about that, but really inclusive of and really emphasizing this upstream look at how we do our work and our science, because I'm really excited about this notion of focusing on eliminating inequities and not just advancing them. But to do that, we really have to get beyond a narrow look at the hospital walls necessarily, and think bigger in terms of the systems we're talking about. In connection with that, I struggled a little bit, and maybe Dr. Guillermo-Ramos, you can touch on this later. That I did struggle a little bit with that, with the notion of what the definition is, or how broadly folks thought about in terms of the healthcare system, and did that healthcare system include? I know it said it was inclusive of public health, but how do those public health prevention systems sort of play into that broader system? And I know it looked at care access, use, and quality. So thinking too in terms of how broadly we can think about that. Let's see. And some of the focus too, in one of the recommendations, or in one area, it says that there was a recommendation around funders expanding their funding for addressing structural racism, health-related social needs, exploring approaches to eliminate inequity. So this, to me, really sort of, again, reinforces this sort of upstream thinking if we're going to be really impacting these areas. In terms of types of studies, you said implementation science, et cetera. And I too, I've long thought that implementation science is so right for nursing science. It's where we're at. It's where we live. We have such a deep understanding of how things work or don't work in the communities we serve. It's a great place for nurses to be testing and scaling up promising interventions. And inclusive of policy interventions. I like the emphasis on policy interventions. I don't think we do enough of that, and I love that was emphasized here. And the notion that there are limited interventional studies focusing on eliminating racial and ethnic inequities. So the intervention studies that we could be scaling up. I love your comment too on looking at that integration of clinical and social care. That to me is an important place for us. In terms of approaches, I think nursing science can really excel in areas that came out in the report around community-based participatory research, and I also do a lot of practice-based research. So with practice partners, this you talked about in the meaningful community engagement slide. I really like that that notion of this work being community-centered. In the report, it has there's a model that has it kind of person-centered. I think to me that was a little bit of a maybe this is something to touch on later too. There was a little tension to me sometimes to the degree to which we're person-centered and community-centered, or could we be both? And also you mentioned nursing science having a place in leadership and addressing some of these societal challenges around mistrust of science, et cetera. To me, that is a huge place for nursing science, in part because we're always brought up over and over as the most trusted profession, blah, blah, blah. That's an obligation for us. If we're going to hold ourselves up as that most trusted profession, we have an obligation to provide leadership in that area. So I would say absolutely. And then just briefly in terms of specific populations, the report kind of talks a lot about rural areas, the digital and data divide, lack of workforce, lack of enough workforce, as well as representative workforce in rural areas. So that's an area I think we could and should be doing more in, and definitely indigenous populations are talked about in the report quite a bit too, and I think that's a space for us. So I'll stop there and hand it off to Dr. Doss.
Thank you, Dr. Beckmeyer. Good morning, everyone. Good morning. It is so good to be here. And first, let me thank you, Dr. Guillermo Ramos, for that great presentation. I thought it was insightful. And thank you for your work to make sure that the nursing perspective was strong in this Ending Unequal Treatment report. And I do want to also thank our director, Dr. Zank, for her courageous leadership in making sure that we broaden the umbrella of inclusivity in research, and we go after the instigators of these inequities, the upstream factors, those structural level factors. I heard you loud and clear, Dr. Guillermo Ramos, when you were saying, where should I start the timeline? It's a struggle I often encounter myself. I go back to 1865, and I go back to that time because there are two instances where the federal government had focused resources and attention on these issues. 1865 under the Lincoln administration, with of course, the ending of the Civil War, ensuring that newly freed Black people and poor whites at the time would have access to these resources, would be able to address their social determinants of health needs. We saw how opponents of health equity, the forces of ill will, as Dr. King called them, fought to eliminate those opportunities for marginalized and under-resourced groups. Then again, there was another opening where the federal government, again, paid attention and invested resources. In the 1930s, they created the Office of Negro Health Work. They focused attention on looking at disparately impacted population groups. But then what happens? Before those could be sustained, opponents of ill will went in and eliminated those opportunities where we were seeing improvements in life expectancy among these population groups. Now, here we are today, and I want to start now at the Heckler Report. I'm so glad you started with that one, because this has been, I think, for many health equity researchers and scholars, it has been our charge. And I wanted to read this because I think it speaks to Dr. Zank and the team here at NINR and your courageous leadership. It says, basically 4 decades ago, HHS Secretary Margaret Heckler, under the Reagan administration, declared, and this was her quote from the report, "Despite the unprecedented explosion in scientific knowledge and the phenomenal capacity of medicine to diagnose, treat, and cure diseases, Blacks, Hispanics, Native Americans, and those of Asian and Pacific Islander heritage have not benefited fully or equitably from the fruits of science or from those systems responsible for translating and using health sciences technology. She goes on to say that the Task Force on Black and Minority Health was thus conceived in response to a national paradox of phenomenal scientific achievement and steady improvement in overall health status, while at the same time, persistent, significant health inequities exist for minority Americans. As the task force came into being in April 1984, it was evident that to bring the health of minorities to the level of all Americans, efforts of monumental proportions were needed. Are we then surprised, right, at the conclusion that you made earlier, that limited overall progress in the elimination of healthcare inequities has been realized? Because we haven't invested time, resources, the human capital that we need to, at the level that we need to address it until now. And I'm so, again, excited by NINR's focus on the social drivers of these inequities. Why is this important? As we're moving forward, I'm glad you also made the case with our health economists. And while we know that the moral arguments should be sufficient, we know that's not necessarily true. And in a recent report that my team and I published, we were looking at both diseases of the brain and our systemic health, trying to understand what are the current and the projected costs of inequities because of our failure to invest in this kind of research. And what we found was quite alarming, right? As the nation is rapidly becoming a racially pluralistic society, a majority minority country, the death rates, premature death rates, excessive, loss of life and years of life lost and so forth continues to increase exponentially. What does that translate economically and from a national security standpoint? And what we found was quite interesting, that in this year, in 2024, we're expected to spend $477.5 billion. And that's just owing to the inequities, the differences, if you will, among population groups relative to these chronic diseases. And at the rate that we're going by 2040, when it's expected that we will be a majority minority country, that number is expected to balloon to almost 1.3 trillion. Very conservative number. And when you compound that from now until then, you're talking about $14 trillion with a T. Huge. So I think one of the things that gets me really excited is the work that folks have been doing, where you mentioned that critics often question whether SDOH interventions truly work. The evidence says they do. And research that was conducted by Drs. Hall, Refunder, and Metzler concluded that downstream interventions, which focus on change at the individual level, are more likely to increase health inequality than our upstream interventions, which focus on social change or policy change. You know, the Delaware housing study, for example, demonstrated that community-based interventions addressing housing insecurity resulted not only in improved health outcomes, but also in significant reductions in healthcare costs. Programs like that show basically that addressing the social determinants of health, or the drivers, whether through improving transportation access or stabilizing housing, can prevent the onset of chronic diseases, reduce emergency room visits, and improve the quality of life for individuals and families. But to improve the health across the board among every population group, this is what we need. And I heard you loud and clear today, and I heard the committee's recommendations loud and clear. We need to continue to assess the social constructs of race and ethnicity in research. We need to address key research gaps from an intersectional, a social, ecological, holistic, and integrated approach, as Dr. Guillermo Ramos mentioned. We need the evidence on structural level and social determinants of health level interventions to reduce health inequities and advance health equity. And I think we need to do a better job, based on what you have said, with those who are criticizing these interventions, effectively demonstrating the causal link. And then, of course, ultimately, secure action-oriented interventions in these underaddressed and often ignored areas of importance. So I will stop there and just say that I'm quite pleased that you have highlighted areas that I think are holding us back, from the myth, if you will, the zero-sum myth that has been, I think, plaguing us for decades. I appreciate when you talked about effective healthcare delivery models that are integrating social and clinical care, utilizing an equity lens. I think that is exactly part of the problem. We have not done that, right? We have not moved with that equity lens in there. You also mentioned, and the work that I did with the committee, with our commission paper, looking at the successful and unsuccessful interventions, what we found was exactly what you just said, right? That most of the interventions were unsuccessful because, again, most of them focused on the individual level. They did not bridge the clinical interventions with those social determinants of health interventions. And I think what you are doing here at NINR is on the right track. It's going to help us to secure and scale up the kind of interventions that will help us to move the needle. I also appreciate that you brought up the clinical tools, the algorithms, and those biased cognitive assessment tools to kidney assessment tools, heart disease assessment tools. And I've been in rooms where folks have said, oh, it's so complicated, so complex to change these. I'm glad that that was recognized. It's, of course, some of the highest hanging fruit. And if we're really going to make a dent in these inequities and close those gaps, we have to go after that. I'm glad, and I hope that the NINR will focus on those more challenging issues. The data collection and reporting, we all know if there's no data, what do folks think? There's no problem. And so I'm glad that you recognized and you all have put a spotlight on the need for patient-level race, ethnicity data, tribal affiliation, language, of course, is another critical component. One that, from a policy standpoint, and since you raised laws and policies that reduce inequities not being able to be implemented to the degree that they need to, I think you're absolutely right. These are areas that we have fought and advocated for, and we have studied, and we know that they work. But again, they have oftentimes not been given the time to stand on their own legs to show the effectiveness. So with that, I will conclude and just say thank you again for your service on that committee. Thank you for your presentation and for opening up our minds, stretching the boundaries of our knowledge. I appreciate the opportunity.
So thank you, Dr. Beckmeyer, Dr. Dawes. Just a couple of thoughts, and now I'm going to just speak more as sort of Vincent, as a neuroscientist, and kind of my own reflections. So I agree that if we focus primarily on individual level sort of factors, particularly as healthcare is designed today, that we'll wind up with a largely ineffective intervention for the kinds of things that we're trying to do, which again, in my mind, is the elimination of health and healthcare inequities. I think where I get a little concerned, and I just want to sort of put this on the table for the council, is that a lot of the current evidence is also based on a flawed model. And so if we were to reimagine what is really a different kind of healthcare system that does integrate clinical and social care, and we fully embrace that there are going to be things that are not going to be resolved within the healthcare system that are going to need to be resolved, and where we're going to need to make interventions in the health system, what might then the effects be? And might there be more symmetry there? And so in my mind, some of the most compelling questions are around leveraging the nursing workforce and other health professions to be trained to provide clinical and social care in different ways. And could we get at more of the effects that we want? Certainly not in any way discounting what many call in public health upstream factors. I agree with that. But I think that sometimes there's this dichotomy that I think is troublesome, because I could also argue that there's evidence, and I don't necessarily agree with this, but I'm just taking on that other cap of people that have this kind of view, that we don't fully understand the mechanisms across different contexts, how sometimes those upstream interventions are affecting sort of downstream factors. And so I think there's a real opportunity as a country to say, hey, we know that there's this healthcare system, we can do more. If we were to reimagine what that looks like, let's take a prototypical nurse graduating in 2030, and if he or she were trained to really integrate care in a way that's fundamentally different, how far would that get us? And then on top of that, can we make changes in the broader health system? And with that, amplify the effects of what's happening in both? To me, that's what we need to figure out, and where I see lots of opportunity. It's a new model. It integrates social and clinical care. It fully recognizes the broader context in terms of policies and structural factors. It highlights mechanisms, and it's not a dichotomy of one or the other. There is a paper coming out in the American Journal of Public Health that Georges Benjamin and a number of the committee members, including myself, authored that is getting at this point about public health and clinical care. And how do we think about it differently?
Oh, Vincent, thank you for that presentation. And I want you to put on your former nursing dean hat next to another nursing dean and really think about, because a lot of the conversation seemed to be around thinking about this nursing workforce and just kind of what you said as well. And we know that our nursing education system was really in many ways inherited from hospitals and their need for staffing. And that was really kind of focused inward, this bedside nursing care. And a lot of what the report seems to point at is we have to think about upstream and social determinants of health. And we know that within this nursing education system, we're having real challenges in one, that it's a very expensive and narrow pipeline. It's not very inclusive. I mean, we want a more representative nursing workforce, but I mean, we were just talking today about some of the challenges of getting a really diverse student population in there. You know, we have issues around nurse practice readiness. We have nursing burnout. We know that we're losing some nurses in the first year, like some estimates 20%. And so those are, I think, an opportunity that for us to really think about turning nursing science and looking at nursing education and kind of, I've talked about this, but reimagining what nursing education looks like. Did the report provide any suggestions about how we can really kind of like, shake the etch a sketch and really rethink how we're doing nursing education?
So the quick answer is yes. The report does talk about that, and there are specific, in Chapter 5, there are specific suggestions for nursing organizations, including schools. It's framed around health professions education, but it does lay a blueprint for the kinds of content and competencies that our workforce is going to need, particularly with new roles, with an interprofessional approach, with much more locational flexibility, with an emphasis on relationships, with really thinking about moving away from biased care. It directly comments on some of the things that have been dominant in many health profession schools around unconscious bias training and really the evidence for that. And is there evidence for that? And what we should be doing where there is evidence, which is much more behavioral focused and more sustainable long-term kinds of interventions. There's a lot in the report around schools. What I will say is, Bob, I definitely agree with you. I would argue that if I think about nursing, initially we, as you know, because I've actually read papers that you've written about this, we initially were not in hospitals. We actually were tied to communities and to war context. And because of the proliferation of hospitals and the need for a workforce, nurses over time became sort of co-opted into those settings, and we became more and more an acute care workforce. And that setting then dictated what many of the schools did. Well, the country needs the nursing workforce and all healthcare professionals to really achieve population health for our nation. There's a critical moment to turn things around, and we've got to be willing to go where the country needs us. The most challenging issues that we face as a nation, that's our opportunity. It doesn't mean that acute care settings aren't still important, but there's a lot that we could be doing that is outside of those contexts.
Yeah, thank you so much, Vincent. I think you made it really crystal clear and make it really simple for everyone to understand the message from the report, including the differences between the disparities, the inequities, but also the impact of ending unequal treatment for, it's for everyone in a society. And I think that message is really important. And I really love the component about the equitable implementation. So very wide adoption of implementation science nurses are leading, but I think even for practicing nurses or nursing workforce is that equitable implementation. Could be at the bedsides, could be at the communities. And I think that's also a critical component where, reflecting about all the amazing work that NINR has already been doing and leading in Director Jen's report. But reflecting some of the questions, Robert, that you asked, I think it's critically important that we educate the nurses when they're in schools so that when they go out and practice, and I'm thinking about this interprofessional, we don't really need all the nurses to become a social worker or to become a public health professional. It's that team-based, and with your recommendation, innovative health and healthcare delivery models that nurses can lead or participate in these interprofessional, and also thinking back about interprofessional education when they're in schools, and how can we, educate them when they're in school, and so that when they go out, part of it is creating jobs that will be attractive, and health systems or healthcare systems think about this. Yes, we need integration of social and clinical care models, but we also need evidence to convince health and health systems leaders or funders to really look at where is the game when we are, designing, implementing such models. And I think there are a lot of pilot studies that are already, some of NINR have funded, but it's like creating more evidence and make messages just even as clear as the report is creating those evidence to the society. And there are a lot of barriers, and we need to think about as we're advocating for this integration that maybe we are putting burden on these social care and community-based organizations that have no infrastructure to support a closed loop social care referral back to large healthcare systems that have these billion-dollar spending on electronic health record systems to create that streamlined closed loop referral to these community-based organizations, social care organizations with the healthcare services. So I think even bearing in mind about as we're implementing and learning from this report with equitable implementation, are we creating more burden in these organizations by suggesting yet not giving them the adequate support, but even asking researchers to pursue and seek evidence in these areas? And I think that's an area maybe is what NINR, and as we are kind of collaborating with other institutes, we can also think about. But again, thank you for the amazing report and representing the nursing community and dissemination of all of this to a wider audience.
Can I just maybe respond to that if it's okay? So I think you're raising some really great points. And I think many of the arguments that a number of individuals have raised around why the integration of clinical and social care may be unwise are sort of the basic argument is similar to what you're articulating. I see this as, I see three ways that I'd like to respond. The first is, I think Professor Dawes and Dr. Levice and Dr. Gaskins have really documented the inequitable cost of what we currently have. And if you really look at that dollar amount, forget about sort of doing the right thing, which obviously I want to do, but just look at the sheer numbers. It's overwhelming. It's clear that we can't sustain that cost and that we need to do something different. So that's kind of point number one. Point number two is that we did critically ask as a committee, what evidence do we have for the integration of clinical and social care? There were many models that we reviewed, and probably one of the most exciting was the 1115 Medicaid waiver demonstration project. And so there was some preliminary evidence. I'll just pick one state, largely because I'm familiar with that state. It was the first state that got an SDOH Medicaid waiver, which is North Carolina. Well, the North Carolina data, Secretary Kingsley, who presented on that, he provided a number of things, and this is public information. It's in a press release from North Carolina. He provided evidence that they had reduced the cost of care to people that were in rural communities in North Carolina that prior to the integration and the use of the Medicaid dollars had not had access to care. Their program looked at housing and clinical care and a combination of the two, and food. It was food, housing, and clinical care. Number two, they were able to show that the community-based organizations had been, struggling, right? Many community-based organizations were struggling, but having the ability to get reimbursed through the Medicaid dollars provided a revenue source that really created sustainability for those organizations and started to allow them to actually hire people and to bring people into the workforce that were not getting employed in the formal healthcare system. So again, it's one state and we need to be careful, but those Medicaid demonstration projects, and this is something that I'm working on now at Hopkins, carefully evaluating what are each of them doing and what are the results? Because I think we need to take advantage of these kinds of natural experiments to describe what's the value, so that we're not making statements. And again, this is not directed at any person, but it's really directed at all of us that are not rooted in kind of the evidence. That did not pan out in North Carolina. In fact, the community-based organizations benefited from having those additional resources.
Wow. Okay. I wish we could keep going. The good news is that we're going to have a large amount of time this afternoon to continue the conversation. So I'm going to pause us there. I want to thank you, Professor Dawes, you, Dr. Beckemeyer, the committee for sharing their thoughts, and again to you, Dr. Guillermo Ramos, for ditto what Dr. Wang said, representing the nursing perspective and your commitment to sharing the committee's recommendations with all of us. So with that, I'm going to say, let's take a break. And we'll come back at 11:15. So we'll see you in 12 minutes. Back. Just one housekeeping item before we move forward. When our council members or others speak, if you don't mind speaking closer to the mic, to make sure the recording is good, so everyone forever can hear your remarks. So that would be much appreciated. So with that, we will now hear from our Deputy Director, Dr. Courtney Acklin. So she's going to, as I said this morning, share an overview of our work in health equity. So this is really just to give the committee, the council, a sense of where we've been, what we're currently doing, and then a little bit more about how our perspective has evolved over the last few years. And then again, I'm really pleased to have an NINR funded investigator who does community work, who's going to talk about what she's doing and how her work exemplifies how nursing research, no pressure, can focus on health equity. So I'll turn it over to you, Dr. Acklin.
So thank you very much, Shannon, for that introduction. And I will say, as I recognize that this is the session between us and lunch, that I will be very succinct in my comments. And I also want to make sure I give enough time for Dr. Werning to be able to share her research. Thank you, Dr. Guillermo Ramos, for your comprehensive overview of the NAM report and your thoughtfulness in describing the role and opportunities for nursing science. It made me take a look and see that some of the gaps are actually addressable. And the good news is we've already started walking in a pathway to be able to do that at NINR. So what I'm hoping to do today is, with both your conversation, Dr. Zink, and your conversation, Dr. Guillermo Ramos, is to set the stage for collectively what we've been doing and to provide a summary of what NINR has been doing in relation to our North Star. But it's sobering to think about the work that remains to be done, despite the focus and the attention that's been given over the years to address these inequities. But again, I'm excited, though, to share the journey that NINR has been on and the process that we've been doing to paint a picture of the intentional way that we have moved forward to achieve health equity. We can stay on this slide. As you heard in Dr. Zink's health introduction, health equity is our guiding North Star. That means health equity is central to the work that we do, the work that we support, and as you can see from our mission statement, central to our vision. For those who are familiar with 2022 to 2026 strategic plan, which I'm going to assume everyone around the table is familiar with, It's a focus on health equity as one of our primary research lenses, and it has shaped the direction of so many of the activities that I'm going to explore in a minute. Throughout my talk this morning, though, I just want to be able to share our North Star has provided a strong shared vision and drives every effort forward. By prioritizing health equity, we are purposefully committing to elevating its importance and therefore creating accountability for ourselves and our partners to ask those difficult questions and to seek solutions to the most challenging and complex health issues so that everyone can reach optimal health. But our prioritization in health equity has shown up in several ways, and I'm going to spend some time sharing those, including the landscape of our portfolio, the crafting of our funding opportunities that target addressing health equity specifically, and striving moving forward to obtain health equity, and by leading and collaborating in partnerships that are also focused specifically on achieving health equity. Next slide, please. So as we heard Dr. Guillermo Ramos describe earlier in his talk, there are several challenges that have been outlined in the NAM report, and they are daunting. But these challenges are not new to nursing, not new to nurses at all, and they have been on the front row seat to the implications and the impact of these health disparities and inequities. Nursing science at its core, as we know, the tenet is approaching these challenges holistically within the context of people's lives and living conditions. Addressing these health needs requires, though, that we seek out health equity and we make it imperative and we follow our North Star. Again, our purposeful prioritization of health equity has led to the expansion of our portfolio that reflects positive changes in our budget allocations, our study enrollments, and the composition of the work we support. Next slide, please. But it's one thing for me to just talk about shining a light and sharing the vision and being purposeful about the trajectory that we follow. It's another, though, to highlight and reiterate, as you've heard already in some instances, the evidence of the changes because of the work that we've already been doing. The work that we've been doing led up to the establishment of our 2022-2026 strategic plan. And now through the strategic plan, we have had the ability to design and be bold and to lean into historical position that nursing has had in addressing the intensifying inequities in social determinants of health. We've made good progress to date. I'm not saying that we don't have much more to do, but we've made much progress to date as our portfolio has expanded. And I'll say that again, as our portfolio has expanded to truly exemplify some of the things that you're seeing here. Nearly 50% of our allocated budget goes to supporting health disparities research. Approximately 65% of our studies have a behavioral and social science bent, placing NINR as the institute at NIH with the largest portion of our budget being spent on this type of research. For social determinants of health, which is closely tied to health equity, we have tripled our investment since 2020, with now 47% of our budget attributed to SDOH work. And of course, I'd be remiss if I didn't talk about our commitment to prioritizing health equity also showing up in the enrollment of our racial and ethnic minority participants in our studies. Inclusion of Black and African American participants rose from 20% in 2020 to 30% in 2023. Also, in fiscal year 2023, we saw the highest level of enrollment for Hispanic and Latino participants during the span of this 9-year assessment. So something that we were incredibly proud of, something that Dr. Zink came in and specifically championed. We have an individual with us now, our scientific diversity officer, who's also helping to lean in. And this is a huge focus for us in terms of our outreach and partnerships with the scientific organizations that are helping to withhold this. Love it. Next slide, please. So Dr. Guillermo Ramos mentioned this a little bit, but I'm going to highlight it for a second because I think it's important to see. At our last council meeting in May, we did talk about the fact that our grant portfolio is reflecting our longstanding commitment to health disparities research. And the fact is our efforts continue to expand this because if you take a look at our council and the grants that are coming through, you will see, if you drill down a bit deeper, that for us, the investment in this area, specifically for fiscal year 23, 46% of our budget, or approximately $90 million, went to supporting projects that we categorize as health disparities research. As the chart indicates, that puts us number 2 at NIH in this category as a percent of our budget. I'm sure you can probably take a guess what that first one is, and I think actually Dr. Guillermo Ramos stated NIMHD stands as number 1. Next slide, please. So let's drill down a bit further. We recently conducted an informal analysis of our current grant portfolio to determine how many of our current projects could be categorized as health equity research. Now, the reason for naming this analysis as informal is NIH does not currently have a standard definition for health equity research. Therefore, there's no official reporting category. We couldn't use RCDC. So I want to also give much applause to our division that did this legwork without having an automated way of doing so. But it gives us an opportunity to take a look at health equity research as the research that addresses a health disparity, examines structural factors, and is community engaged in this approach. So if you take a look at newly funded work, so looking at our type 1 grants, for example, in our NINR projects since 2019, our funding support for this area of research has continued to increase substantially from under $1 million to nearly $6 million. But keep in mind, again, that this is a preliminary analysis with relatively small numbers. So I am encouraged, though, if you take a look at the trend that we see here, and the increase in the applications also tend to reflect this trend. We have a ways to go, but we've got a direction and we have a pathway forward. And as you can see, we're moving on that path. Next slide, please. So while we're proud of the investments we've been making that show the expansion of our research portfolio, we're also proud of the attention and focus of our extramural programming efforts to lead NINR to health equity activities that we've assisted in driving the changes. So I wanted to just point out a few of them to you. Next slide, please. Specifically, over the past 2 years, we have issued 8 requests for applications, or RFAs, centered around achieving health equity. Impressively, as these RFAs, half of them have resulted in the highest number of applications to our RFAs in available NINR history, going back as far as 2014. But as you can see from the topics listed here, they span a broad range of focus on healthcare systems, particular populations of emphasis that are most vulnerable to health inequities, examining these challenges with more upstream solutions, and ultimately examining a role of research outcomes that can potentially impact policy. Next slide, please. So again, I wanted to highlight a couple of our opportunities specifically and talk a little bit more about what they are, how they were developed. The Bridge to Care initiative focuses on integrating healthcare and community services to address social determinants of health and improve health equity. Recognizing that healthcare alone cannot address factors influencing health, this initiative was designed to promote healthcare community partnerships to handle unmet social needs such as housing, food security, and economic stability, which often result in poor health outcomes. This initiative is supporting research to evaluate and enhance these partnerships, emphasizing intervention and evaluation studies targeting underserved populations who are facing these health disparities. But the goal is to ensure effective and sustainable programs that can enhance health outcomes both at the individual, but also at the community level, to get at some of the conversation we had earlier about making sure that we're moving beyond now just interventions targeted for individuals. Through our original release in 2023, we funded projects last year that focused on revising the clinical cascade as the systems level to improve access to the treatment of opioid use disorders as people transition from incarceration directly to communities, increasing school attendance, and ultimately improving the well-being of children and families using a school-based community health worker program, improving the accessibility of crucial early childhood special education services through a preschool program, and a program for Black, Hispanic, and low-income children with developmental delays and disabilities. Next slide, please. As we'll discuss and see a little bit later live with Dr. Horning's work and her community engaged focus, it is so important for us to have community partners and to really exemplify and show nurse-led models of care. We heard today by both Dr. Guillermo Ramos and Professor Dawes the mention of just how important it is to move again beyond individual level interventions and to create those interventions at a structural level with an eye on the outcome that could do more than just the intervention there, but to perhaps really push policy change. We're in a space of already encouraging that movement forward. As an example of our efforts to truly push the envelope for change and how we address health inequities can be seen in one of our funded studies under the Bridge initiative that focuses on addressing maternal health disparities through integrated supportive care models that evaluate Medicaid-supported doula programs. Recognizing the stark inequalities in maternal mortality rates for Black individuals compared to white individuals, this study is leaning in to work to enhance access to respectful, culturally congruent maternal services. It leverages recent policy advancement, like maternity hospital quality improvement networks and citywide doula initiative programs, to provide low-income Medicaid-eligible individuals with doula services at no cost. Through a mixed methods approach, the project evaluates the impact of these programs on health outcomes and healthcare utilization among diverse populations. In addition, this project also seeks to overcome the barriers of sustainable policy implementation. So again, getting at one of the gaps that has been explained and exposed already in the NAM report. But it is our strategic goal to also make sure that we are creating an opportunity for community-driven interventions such as these to have a place. So we will continue to move forward in supporting work like this. Next slide, please. We must continue to press forward in making sure that our solicitations for research center on intervention strategies that are designed to go beyond just identifying challenges. We need to be able to have studies that can help address some of the contextual issues described earlier in the discussion by Dr. Beckmeyer. Through our most recent RFA listed here, we have solicited research centered on intervention strategies designed to specifically examine social determinants of health and to address overall health equity. For the rural health-focused RFA, this funding opportunity supports the research to develop, adapt, and implement strategies that mitigate adverse SDOH and leverage positive influences on health. It emphasizes community engagement to ensure interventions align with rural community practices, needs, and strengths. And I'm going to highlight strengths, and you'll hear me talk a little bit about it later because I think it's an important component that I haven't really heard us discuss much before, is that importance of leveraging strength. The research supports various approaches, including community-based participatory research to foster solutions tailored to a rural context. In this particular case, we're going to discuss a little bit later the responses to this RFA during our closed session as we have applications in hand. The Access Initiative looks to advance an understanding of health disparities through an intersectional lens, focusing on how social determinants of health and various social statuses intersect to influence health outcomes. Recognizing that systems of privilege and oppression such as racism and classism drive health inequities, the initiative that we put out is seeking really to encourage researchers to uncover pathways and mechanisms underlying these disparities. It's emphasizing the use of innovative methods, so again, with the eye to push the envelope, to examine intersections of race, ethnicity, socioeconomic status, gender, and other social positions that affect health, especially in marginalized populations. And I'm happy to say that we are expecting anticipated awards in our next fiscal year. And lastly, as you had heard mentioned earlier today, we are really excited to announce an intent to publish an initiative on interventions to prevent and address housing instability with an expected outcome for October for October launch. Next slide, please. So keeping with the same theme of building the evidence and providing opportunities to support examining health equity with a focus on societal impact, I want to share one more example of a nurse-led intervention in response to a PAR on community intervention to address the consequences of COVID-19 pandemic among health disparity. This particular study has focused in on underserved racial and ethnic minority communities, specifically African American adults with chronic illness who are recovering from COVID-19, along with informal care partners. Recognizing that communities face disproportionate impact from COVID-19 due to social and structural health determinants and pre-existing chronic conditions like diabetes and hypertension, the study is testing a telehealth enhanced intervention that is being delivered by a registered nurse and community health worker team to address racial and pandemic related stressors and supports the management of this dyad in the chronic disease management. By enhancing the efficacy and the agency of both patients and the caregivers in managing the illness behaviors through coaching and health system navigation. So again, having the opportunity to look more broadly than just individual level interventions. Through rigorous evaluation and community input, this study is working to reduce health disparities by tailoring healthcare approaches to the unique challenges faced by this population. Next slide, please. So along with our efforts, our research portfolio to expand that and to aggressively create opportunities for our researchers to come in and support the effort and the work that we've laid the ground for, we are also in a really strong position to lead by partnering, collaborating across NIH to help make sure that when we move these NIH-wide efforts forward, that the opportunity to explore social determinants of health and to really talk about health equity and to partner with communities remains front and center. Next slide, please. So you heard earlier from Dr. Zink the latest updates for Improve, but I wanted to underscore the importance of this program as it aims to reduce maternal health disparities by engaging community partnerships and tailoring approaches for those most affected, including African American, American Indian, Alaska Native populations, and individuals lacking access to maternal care. Research efforts to date align quite well with NINR's approach. I wonder why. We have one of the co-chairs sitting right next to me. And with her leadership, we've been able to truly infuse and make it clear that we need to have an understanding of the impact of systematic factors that are driving these disparities in order to address the high rates of maternal mortality and morbidity in the United States. They're awarding over $40 million to establish the maternal health research centers of excellence across the country, to the most recent update regarding the challenge awards that were given to community organizations that Dr. Zink presented earlier. Improve is creating a national network focused on developing tailored interventions and identifying risk factors for maternal mortality and severe morbidity. NINR has been involved in all stages of this process and of this initiative and has really helped to infuse that a focus remain, again, on addressing social determinants of health and overcoming structural barriers to address something that we know is a preventable health disparity. Next slide, please. And I won't talk much about Compass because I know that there was a meeting that just happened and you heard the update earlier, but I will go back to just reiterate how truly impactful this initiative has been designed and what it's aiming to achieve. Launched officially in fiscal year 2023, although I will say much work began before that with the listening sessions and an OTA to really set the stage to make sure that voices were heard in developing and designing this intervention. NINR partnered again, this time with NIMH, NIMHD, and ORWH in the Office of the Director as a founding co-chair to establish a groundbreaking program that NIH has never seen before, that quite frankly, I was incredibly excited to see as a behavioral and social scientist myself, who's always believed that you really can't intervene if you don't understand the community voice. We are providing approximately $171 million over 5 years to support community organizations, with NINR leading the charge in the management of the coordinating center for these centers. But the program, as you all may know, emphasizes the role of social determinants of health by fostering the collaborations between community leaders and research partners from academic institutions. The research focuses on developing, implementing, and assessing structural interventions to create sustainable solutions that promote health equity. By addressing systematic issues that lead to health disparities, the projects supported by Compass are all aiming to improve health outcomes in the communities across the nation. Examples of projects include initiatives to enhance access to healthy food, improve childcare strategies, facilitate better healthcare access and quality for marginalized groups, and expand telehealth services in rural areas. So as you can see, yet again, there's quite a lot of alignment in what we've set up in our strategic plan, seen here. Again, I'm going to give a head nod to the person sitting next to me and the involvement in being able to infuse the importance of nursing science. Next slide, please. So all of this is to say and to summarize and to have the conversation that after hearing the updates and the accomplishments earlier that Dr. Zink presented in her director's talk, and the nature of the gaps that we still must address as outlined by Dr. Guillermo, we've recognized that it's time to revisit our lenses. And that what we initially outlined in our strategic plan does match and is still very much relevant, but just like anything else in science, it evolves. And so we needed to clarify, and it was time to do that. It gave us an opportunity to explore emerging areas of emphasis and the approaches to nursing research that we think had the greatest potential for producing results with the greatest impact. because now's the time to do it. We have the floor, we have the stage, we now have evidence, and quite a few suggestions. Thank you, Dr. Guillermo, for areas to go to. Next slide, please. As we've continued to prioritize health equity as our North Star, and as I shared earlier, expand our portfolio, there are many important scientific advancements that have pushed the need for more clarity on how we continue to move forward in supporting our efforts. As shared earlier, we have taken the time and several discussions and a lot of input and a lot of thoughtfulness around making sure that as we were refining our lenses, we are staying true to our North Star. And so focusing in today on health equity is our way of doing that. Dr. Zink mentioned earlier that we have updated our language, and in July, after much discussion, we released that, and you should be able to see our updated lenses on our website. And we're very proud of where we are with this, because now we have an opportunity to really share our North Star with our investigators. We've now provided additional clarity of the type of research that we'd like to see, with full recognition that this is where we're able to make an impact. Next slide, please. Next slide, please. So focusing in on maximizing our impact, at NINR, we have put real emphasis on supporting rigorous science that truly has this potential to make an impact. We want research that goes beyond observing the problem. We need to intervene, and we need to make a difference, and now is the time to do that. A view of our health equity research is reflected in how we describe this lens in our strategic plan, and as Dr. Zink indicated earlier, it is time to make this change. There are several characteristics of the studies of health equity that we believe are essential, and we want studies that are seeking to make an impact. And to do that at a foundational level, studies must incorporate a focus on health disparities, first and foremost. And we know that addressing health disparities is an essential step to achieving health equity. We're interested in studies, for example, that examine contributing factors and pathways and mechanisms underlying health disparities, but we're also interested in testing interventions and other approaches for their impact on health disparities. And it's because we are looking for this intersectionality that we wanted to also clarify this particular lens. Next slide, please. But as it's been pointed out, we need to provide more clarity in the goals of what we're trying to achieve, and the revision of our health equity lens is our way of leaning into providing more clarity and guidance for our investigators who are interested in this work. Through the identification of these three keys, we are purposefully highlighting what we are looking for: research that examines interventions on structural factors, and research that is meaningfully involved, marginalized and monitorized communities and populations. But what I'd like to point out here, and it's something I mentioned a bit earlier, is the importance of examining health equity and looking at it not as a deficit model, but as a strength-based model, and really leveraging and amplifying the voices of the community, their influence, and making sure that we pay attention to not just the deficits and the health disparities, but really where we can take what we see in terms of strengths and be able to apply them in different areas. A study that incorporates all three of these keys and our conception stand the best chance for having an impact on health equity. And we are striving forward. Don't see us slowing down at any point. As a matter of fact, if you go back to the data tables I showed you, everything is pointing to us moving forward, chasing that North Star. We want to move forward and make sure we're incorporating all of these principles, and therefore provide additional opportunities to realize the impact necessary to end unequal treatment. NINR has been in this. We are in it now. And a little bit later, we'll talk about where we need to go. And I'm hoping that all of you will lean in the discussion and helping us to determine what those next steps look like as we all head underneath our North Star. Next slide, please. And with that, I'll just say thank you for your time and really appreciate having the opportunity to be part of this conversation as something that we hold near and dear.
Thank you so much, Dr. Eklund. So now I welcome NINR funded investigator, Dr. Melissa Horning. Dr. Horning is an associate professor at the University of Minnesota School of Nursing. Her current research focuses on evaluating the effectiveness of a mobile food market in bringing affordable and nutritious food to underserved communities and the impact on diet quality, food purchasing habits, and food security. Dr. Horning is not joined virtually. Unfortunately, her community partner was not able to make it today. So we'll catch up with that partner later. But again, thank you, Dr. Horning, for joining us. And we're looking forward to hearing more about your partnership and your research.
Thank you so much for the invitation. Steph sends her deepest regrets. She's been planning to be on vacation for a long time. And so she was planning to call in, and she's just too remote to be able to do that. So she's really sorry she can't be here. But she told me I could present for her. With that, I will get started. I come to this work by way of public health nursing. As a public health nurse, one of the greatest tools in my toolkit was partnership with both my clients and the community resources and organizations that supported them. Because without partnership, I couldn't have done my job well. The focus on food also came from my clients because they were worried about accessing food, affording food, for some preparing food and getting their kids to eat well. And I think we can all agree in this room that nutritious food is essential for healthy growth and development of our children, the prevention and management of chronic health conditions, and aging well. But unfortunately, not all people have access to the food they need to live a vibrant and healthy lifestyle. And food insecurity is in fact the limited or uncertain access to adequate food. And this doesn't begin to address nutritious food. And we know that food insecurity is contributing to health inequities that are related to diet, weight, and other health conditions. And as research has shown time and time again, it's contributing to a host of poor outcomes that really make it a major public health concern. Oops. The slides are just like advancing on their own will. Food insecurity impacts 1 in 10 in the United States. Unfortunately, this impact is not equitably distributed across our communities. Food insecurity disproportionately impacts many individuals from minoritized racial ethnic groups and those, it's like jumping 2 slides at once here, folks, and those that are lower socioeconomic status. And the thing that's really important to know is that food insecurity, while it's caused by many things, major contributing factors are those structural and social determinants of health that we've been talking about all morning, the systems and structures and conditions in which we live, grow, work, and play. In particular, structural racism is contributing to food insecurity through historical and current chronic disinvestment in communities predominantly of people of color and or low socioeconomic status. Structural racism is also contributing to food insecurity based on where full-service grocery stores choose to operate, as well as where they're allowed to operate through zoning policies and laws. We also know that economic instability and limited employment opportunities are contributing to food insecurity when faced with multiple competing needs, housing, heat, and food. As my community partners like Steph like to say, food is pretty flexible. We've all seen the rising costs of food in the recent years. And we also know that based on the location and types of stores available in your community, prices vary dramatically, with smaller stores tending to have both higher prices and lower quality foods. This map is from the United States Department of Agriculture and is of the Twin Cities metropolitan area in Minnesota. And the areas in orange are those that are census tracts that are experiencing low income and low food access. And as you can see, low food access is not equitably distributed across our community, but this is echoed across the country. And so as a public health nursing researcher, I've wrestled with, so what do we do? How do we intervene? What's the next step? And so I've seen a lot of really amazing, innovative projects, both in research and in community, live and die with grant funding, and change as a result in funding priorities or changes in leadership. And so I wanted to be sure that I was contributing to something that was potentially sustainable in a really meaningful way to really advance equity. And I knew that I had to go back to my roots as a public health nurse. I knew it needed to be a partnered project. The Twin Cities Mobile Market was founded in 2014 on the values of equity and community engagement. The founding director, Leah Porter, talked to over 1,000 members of the community to really make sure that the mobile market that was designed and built reflected the needs of the people that would be using it. She was committed, and the community really needed the highest quality customer service and quality, affordable foods. This mobile market goes to over 25 sites in the Twin Cities right now that are experiencing low income and low food access, and it's selling foods from all the food groups. And it was initially operated as a program of the Wilder Foundation. This is what it looked like in its early days, and the inside complete with shopping carts. And this is what it looks like now. The buses were just refreshed in the last year. The food group invested in new buses because their old buses were having some serious mechanical issues that would recur. And this is what the inside of the bus looks like now. It still has shopping carts. But it was in 2016 when our community engaged research partnership began. And so when Leah and I met the first time, it was really about getting to know one another and developing a partnership and figuring out what are the needs and priorities. And I knew that that was going to need to involve talking to customers. But in talking with Leah, she said, you know, Melissa, this model isn't inexpensive to run. And so while it sounds good, it feels good, people seem to like it, we need to know if it's actually having an impact. Is it changing food access? Is it changing food security? Is it changing intake? Because if it's not, like, we need to reconvene and figure out what could we do instead. But Leah, so while she really wanted to know the impact of the mobile market, she also didn't want to create yet another barrier to accessing food in the community she was trying to improve food access for. Because of the historical harms of research, she was like, is this really a good move for us? And so I knew that we needed to build trust and rapport. And so for her, I actually worked on a sales data project. She's got gobs of point of sales data, and I was able to really get to know her over the process of doing just like a data analysis project and volunteering for her when she needed a volunteer. And that led us to the point where we were beginning to weave those threads of our community engaged research partnership, where we were writing both research grants and program implementation grants that involved research. And we really emphasized shared decision making. She read everything I wrote, I read everything she wrote, because we were in it together. And that led us to our first study that was funded, and that was with customers. And that was really intentional because, again, the customers are the experts of their lives. And so we really wanted to know from them first, what was the lived experience of shopping at the Twin Cities mobile market? But more importantly, we also wanted to understand better, how do we do research in the community and do it well and correctly? And so we learned a lot of wonderful things from the customers. We also were fortunate to receive a program implementation grant from the United States Department of Agriculture that had a research component built into it. And that actually was really great because it allowed my team and myself to remain in the field, where we got to talk with customers and just hear about their lived experience in their day-to-day. It also allowed us to do customer intercept surveys, where we were able to discover, as you can see on the bars on the left, that food insecurity was a nearly universal experience. And those projects then led us to where we are at this point, where we were able to submit our first RO1 and really being able to engage all the different partners involved in the work. But true to programs in the community, they're operating in a space where things are changing all the time. And so as we were writing our first RO1, the mobile market was actually switching umbrella organizations. And as Steph would like to tell you, it is very, very challenging to transition a program at the start of a pandemic. But that being said, my initial partner, Leah, was also transitioning away from the program. And so all of this historical trust and rapport that we had built up then had to get reestablished. And so it took us some time to get that part done, where we were really, again, looking at what are the aims of this study and what can we do together and what are the needs of the organization and what is the benefit or the potential things that research could bring to that work. And so we were able to be successful in our grant resubmission, and we were funded in 2022 to evaluate the impact of this full service mobile market on dietary quality, food insecurity, and fruit and vegetable purchases. And our third aim is really seeking to explore what is the experience of the participants who are receiving the mobile market as sort of the intervention arm, to understand what's working, what could be done better, or why they choose to shop or don't choose to shop. We're aiming to do this work across 12 new Twin Cities mobile market sites in the Twin Cities, with targeting 264 participants for power purposes. I'm pleased to report we have just begun baseline recruitment and data collection for our third wave of this study. And after baseline data collection, recruitment is done for each of the waves. They get randomized to receive the mobile market, or they have to wait to receive the mobile market after follow-up data collection is done. Hopefully by now you've kind of seen that like the community engagement that we're doing in this work has really been embedded in the project from the very development of the aims to the division of responsibilities. Like they're clearly the ones that need to like be fixing the buses if they break down on the sides of the road. They don't want me in that role. But it's really allowed us to be able to openly communicate honestly with one another as this partnership continues to develop over time, to really value the expertise of everyone that comes to the table. We've had to negotiate budgets. We've had to negotiate budgets after budget cuts. We've had to think about how do we select sites for the trial, because the mobile market has criteria. They have to have somewhere to park the bus. But in order to make it through peer review, we also had to decrease the risk of contamination. And so like navigating those conversations. And then most importantly, how do we interface with the community sites that are interested in the mobile market, seeing if there's a good fit? Because at the end of the day, the people who live in the buildings that the mobile market goes to need to be able to want and think that this is a good idea for them. And so we've really tried to create some really nice feedback loops to value the participant experience, but also the mobile market staff who are on the ground every single day and their customers. And so in the research processes, we've actually sought staff and customer input. So like they're reviewing everything too, to make sure that our measurement processes are in the right space, that we've got the right recruitment and retention strategies, our participant compensation processes are appropriate. And they've helped us figure out how do we make participation really welcoming and easy. And so we're in the community with folks. We try to aim for a really hospitable experience. And we've built in accommodations for everyone. So for example, instead of like having somebody and being like, oh, here's your survey, when it gets to that point in time, everybody is offered like, would you like help reading your survey? Would you like help with the iPad, or would you like to take the survey yourself? Because again, we're aiming for this really inclusive experience where all people feel like they can participate and there aren't these extra barriers to research participation. We also know that research isn't for everyone. And so the really wonderful part about our trial is that the mobile market is available to everyone, research participants and building residents alike. And the mobile market staff actually don't know who's a participant and who's not. And so we actually have engagement launch events where everybody in the building comes before the mobile market comes, so they can learn about what the mobile market is, how it works, and those types of things. And then again, we're seeking that experience of our participants, and we're clearly going to inform our participants of the trial results. And so what we know is that the data are really going to either support the full service mobile market model or suggest that changes might be needed to really pave the way for services that are truly responsive to the community needs and interests. We know that the participants that are in our study thus far are demographically representative of the building populations, and that we've had a really high retention rate across the first 2 waves of our study. We also regularly hear that participants like participating in our study, and I sometimes get really cute notes from them. And then they're also sometimes being like, do you have any other studies we could participate in? But we know that challenges remain. No community actually wants to wait until the end of follow-up data collection to start the service, because the needs are immediate, the needs are now. We also know that research does limit the context in which we can choose our sites. And so like if they're right next to sort of a high-end grocery store, like that's off the list, even though it would potentially be a community site that would very much need the Twin Cities mobile market. And we also know that this is real world implementation. And so the findings are taking into the messiness that comes in being with community. Buses can break down. They have, they will, probably will again. Systems can fail, hiccups can happen, but the results are going to take that into consideration. And hopefully that increases the meaningfulness of that both locally as well as broadly. And hopefully that also then influences the sustainability. But it also comes with the caveat that like while we are aiming to do real world research evaluation, we have this synergistic partnership. And so there's ways in which like my research team and Steph's team have like worked together, and the mobile market isn't the same as it was before our research involvement. For instance, they've always wanted to do a customer loyalty program, and they just didn't have the person power to be able to get it figured out. And yet we had written it into our grant. And so when the grant was funded, my team and their team worked together, and they've now implemented this customer loyalty program across all their sites. And so like it's real world, but we still have this partnership that is synergistic. And so that's part of what we're measuring. That being said, within the community engaged research space, Steph and I have a lot of really honest heart-to-heart conversations, and we talk about how hard this work is. And like, how do you really develop meaningful relationships in sustainable ways? Because partners are changing, programs are changing, communities need follow through, and a lot of grants aren't funded. And so how do we do this work and how do we do it well? We know the timelines to funding are long. And so how do we make sure that we're efficient in the building of preliminary data and development of teams, so it's not antiquated before it's started or before it's finished? And how do we leverage real world implementation? And so we talked about like, how do we do that well while conducting rigorous research? And so can we look at other types of designs? So while we're doing a cluster randomized trial, not all real world implemented research can really entertain that. And so are there natural experimental studies or other designs that might be important to consider? And then ultimately, how do we embed community engagement in the projects in a way that's real? It's not a one size fits all approach. And what I do and what all the others in this room do is going to look different, but then we also then need to make sure that we're being true to the communities that we are working with and doing it the right way for each study, because it's not going to be a series of check boxes. And are we hitting each one? And so those are questions that we talk about and things that are just food for thought, literally as we're preparing for lunch. And I just want to say thank you for your time.
That was great. Thank you so much. So Dr. Ayala, kick us off.
Thank you. Two wonderful presentations, and thank you for giving us time to be able to have a little discussion before lunch. I really appreciated your presentation, Dr. Ackman. It's one of the, especially the first part with the data. It's something that I've been wondering about for a while, so I appreciate getting it. But it also raised some other questions for me. Among them is, can these, for example, the enrollment, the increases in enrollment, can this be explained by who you're funding, institutions and or investigators? So I'm curious, when you think back to what you mentioned about the social determinants of health training, you know, I wondered to what extent are we tracking? Are those people then going into leading some of these grants? And so kind of wondered the synergy about that capacity building, especially with faculty and partners who may be of diverse racial, ethnic backgrounds. And are those investments then leading to these increases in enrollment and whatnot? So what kind of explains those changes that we're seeing, which is fantastic. The second question that raised related to clarifying the health equity lens, the natural experiments and demonstration studies, and this sort of relates to something that you said, Dr. Hornig, is that how are we changing or educating study sections not to still require the most rigorous study designs? Because your design is very rigorous, and so it's probably one of the reasons why it was funded. But not all studies can kind of fit those designs. So I'm just curious, what more can we do to improve that process, the review process, so we don't discourage people from testing out different designs? And then finally, Dr. Elkin, your comment regarding strength-based models, I think that was really clear during the Compass discussions. I think every single individual who spoke up then said we need to have a more assets-based approach and not a deficits approach, because they're trying to build on community strengths as opposed to thinking about them not coming with strengths, including the organizations themselves, because I think that there was a sense that the organizations did not have necessarily the capacity to be able to do this, but it is clear that they've been doing it for a while, just maybe not with a research lens. And then Dr. Hornig, I really appreciated your focus on laws and policies. It reminded me of one of the Compass projects. This is led by a group called Ghana in San Francisco, where what they're trying to do is take street vendors and start to have them maybe build their capacity to have a storefront in all the vacant buildings that are now in San Francisco. And so they really talked about the laws that are needed and policies around that to make that happen. The other thing that struck me about your presentation, and we all know this, but how much time it takes. And it's a struggle that I have as a mentor of a lot of junior faculty of color who really want to be successful in the RTP process, but have such a vision for their research like yours, but are worried about the time it'll take and wondering how it's going to impact their career. So it's balance that I'm trying to figure out how, especially as a mentor, how to support them to be able to advance. One question I have for you, though, is I missed, how did you kind of turn the corner with your partner in terms of her interest in research?
So Leah and I just literally were meeting on this other project. So I was trying to help her out. And just by being human, right? Like developing a relationship, getting to know one another, really being able to talk about like, how can we do this and do this well? And how do we get the customers to inform what we're doing? To really make sure that we're creating a space that's safe. And so I think it was really just developing a relationship with time. And I think that's the trick for investigators, right? And it's the trick for community. This work takes time and investment of resources, both of which are limited. And so it's pretty high risk, high reward, because partners are changing and evolving. And unless your partner is able to weather those storms, you can end up finding like really wonderful investigators facing their tenure clocks and having that struggle.
Yeah, some incredibly great questions. And I think the very first one you talked about in terms of, is it the universities that we're funding and looking to leverage? We're having that conversation now about the partnerships. So we don't necessarily have the data, although Dr. Grayson, you can correct me if I'm wrong on that just yet. But it is something that has opened up our eyes to an examination of, and the full recognition that we do need to support more than likely some of the universities to have the infrastructure to be able to do the work that we're talking about doing. So conversations are coming.
One really might be a silly question, but it was one of your first slides. And Dr. Ekman, thank you for all the work. It was really nice. But I wondered how you differentiated between health disparities research and social determinants of health research, because to me, if you're looking at health disparities, you should be looking at social determinants of health. I was just wrapping my mind around that. How could one fall into the other and not,
Yeah, I'll start by saying, right, not all social determinants of health research is focused on health disparities. Likewise, not all health disparities research, really addresses social determinants. Right now, a question is whether they should, right? But that's, true, right? Some people are trying to address health disparities in other ways beyond addressing through that sort of social determinants of health lens. And then it gets into the more coding, how things are coded here, which is Dr. Grayson's department. So I'll let him add.
Right. So both of those topics, health disparities research and social determinants of health research, are official NIH categories that are done through RCDC fingerprints and all that kind of good stuff that I went into at the last meeting. So those the numbers that you saw there simply come from those. And there certainly, of course, is overlap between those two lists. And one could ask, how well do those fingerprints distinguish between those two categories? But
they're not mutually exclusive then?
No, they're
Okay.
not. No. There's significant overlap between those two lists.
There's been a lot. Any other questions or thoughts before we?
Dr. Horning, thank you so much for your presentation. I can't imagine you started a study with a mobile market that's in closed space starting COVID time. So I am curious and I appreciate you kind of presenting the challenges between the real world implementation versus rigorous research. And I wonder if you could elaborate a little bit more about your challenges. Was these communities benefiting from the food and kind of increase the food security? But in the meantime, during a time, did participants ever want you to move the food outside the mobile market because of COVID? Or I'm just curious, I guess, the challenges you have encountered in this approach.
Yeah, so the trial was funded actually after sort of like normal service had resumed. But in the period between March 2020, and then it wasn't until sort of, I'm going to get the dates wrong, but it wasn't until much, much later that normal service resumed. So for a while, they were actually doing boxes to all the buildings. So anybody in the building could get a box instead of, and it wasn't like you pick out your own stuff and you pay for it. But they were really trying to also recognize that these communities are at the highest risk for poorest COVID outcomes for a variety of intersectional reasons. And so they were really trying to figure out, how do we do this safely? Just because when you have a bus, it's an enclosed space. In the winter in Minnesota, the bus has to be shut because like heat's got to be on. And in the summer, it gets really hot and you can't have the food spoiling. So like they have to like keep it somewhat closed. And so it wasn't possible to really like do it well on the bus in that time. So they had to like change the program in the interim. And this is it. And then like when they were untangling that, then they were launching the program as it was originally for the first time. And so it's like the real world messy nature of being in community and then being flexible with that.
Great. Thank you. And I am also curious about in terms of sort of the science behind it, that we are marrying the implementation science with, real world and partnership with the community partners. I'm also curious about your kind of views on the actual leveraging the real world evidence that's sort of naturally occurring, kind of topping, kind of learning and developing or advancing the science using real world data versus sort of implementing strategies and kind of learning what's the science behind this community partnership. Do you see a difference between the two? And how do we balance in generating evidence within this?
Yeah, I think that's a really good question. With this study, like we're recruiting research participants to really be able to have this, like rigorous results we can trust. But we're also collecting point of sales data. And so we're able to get that systems level sort of look as well to like look at, purchasing trends over time. And so I think that there's ways in which you can do both, right? And so I think it's figuring out like, when a new policy changes, CMS is allowing Medicare to provide provisions of food. And so we're seeing a lot in sort of the food is medicine world. And so like, how do we capture the data that might already exist on some of these programs and health systems and insurance programs that are implementing them? How do we take that and then really evaluate it to understand how is this change in policy contributing to equitable outcomes or not in community? And so I think it's a both and so I think we can't toss our RCTs out, and just like we can't toss out some of these other studies, but then it's figuring out how do we get those types of studies funded. Because, when you put an RCT next to a natural experiment, there's an inherent bias that happens with the natural experiment that like we work our best to mitigate, but like is a tension there. And so I think that those are big questions that don't have easy answers.
Thank you.
So we're at time, but just in case, I'm going to look around to make sure. Okay. I know. Oh, all right. I know. I'm glad I looked.
I appreciate that. Because I was trying to figure out how do I want to say it, but thank you for your presentation. I was excited by what I heard and what I learned. I'm curious, whether you all have, planned to link the data that you have found with healthcare systems, social services system. Have you engaged those partners in that work to address other, issues that are being?
Yeah, so at this point, we don't have plans to sort of link this study with healthcare systems or healthcare partners. The mobile market has a lot of sort of partnerships with the medical healthcare systems. And so like they do sort of like entertain and talk to them somewhat regularly, but like this is separate from that. I think they have actually trialed out sites at like community, like clinics and health systems to varying degrees of success, just because it's a stop once a week. And so you're catching people, who come to appointments on Thursdays at 1 to 4, you know what I mean? And so I think that there was still a lot to think about when you think about how do we refer to places like the Twin Cities mobile market. Some of the health systems have like vouchers where like it's part of their food prescription program. So like there's beginning linkages of that, but we don't have any sort of broader linkages to the health systems at this time. And then if I can add one thing, I realized I didn't acknowledge my partners or my funders when I did my presentation. So I just want to like acknowledge that our work has been funded by NINR, and Steph and her team at the mobile market, our customers, the shopper, or like the shoppers, customers, however you want to call them, our research participants, building site partners really make this possible. And so my apologies for like that serious omission, and thank you for those 2 minutes to say it.
Well, Dr. Horning, thank you so much for joining us and sharing your science and exemplifying community partnership and how that can be closely integrated into research. So thank you for that. And I do want to just note to council, all your comments, we track them over time. Hopefully you see that we are and bringing responses back to you. So know that if we didn't directly address all your questions today, we are keeping track and we'll be circling back. But if ever you find we have not answered your questions, please let us know and we'll be sure to do that. So with that, we're almost perfectly on time. So thank you again, Dr. Horning. And it is lunchtime, and all right, so 12:45. Can we get together at 12:45? 23 minutes. Oh no, it's that I can't even do math. You have like 27 minutes or something. It's fine. It's fine. So enjoy. All right. Goodbye. Okay, welcome back, everyone. So as we introduced this morning, we've allocated the next couple of hours to talking about the future of health equity research at NINR. So as Dr. Ackland mentioned, NINR and nursing research, we believe, has a really important role to play in health equity, and this shows up in various ways. So two of those individuals who can help us think about how we can maximize our impact and leverage the nursing perspective to advance health equity through research are here with us today. We're going to be talking about structural interventions, meaningful community engagement. And so I'm pleased to introduce our first speaker. So welcome to Dr. Monica McLemore. Of the University of Washington School of Nursing. Dr. McLemore is a professor in the Department of Child, Family, and Population Health Nursing, adjunct professor in the School of Public Health and the Department of Women and Gender Studies, and is the director of the Manning Price Spratlin Center of Anti-Racism and Equity. Dr. McLemore's extensive clinical and research careers have focused on reproductive health, rights, and justice. She is a member of the Sigma Theta Tau International Honor Society of Nursing. So with this session, Dr. McLemore hopes to educate and inspire all of us to understand how to retrofit, reform, and reimagine nursing research to right historical harms, partner with people with lived experience, improve health outcomes, and advance health equity. So welcome to you.
Thank you, Director Zank, and it's so great to be here today. It is such an honor. I don't know how you all are feeling, but I have a really big task, right? I mean, I'm right after lunch. So I'm going to try and make sure we don't have like postprandial narcolepsy. I use she and her pronouns, and I am going to do something a little different than I think others have done. Anybody who knows me knows I'm not a traditional researcher in the sense of how I like to present. And so I don't know about you all, but my brain is blowing up. Like I have a gajillion ideas and there's like a million things I want to say. And part of me wants to ditch my slide set and speak from the hip, but I'm not going to do that. I am going to walk you through some slides and try to really get us to reimagine not just health equity, not just thinking about the people that we serve, but how we engage with others and disrupt this idea of communities. I've started to use the word plural because I think that there's so many communities, constituencies, groups of individuals, and interested parties who can directly benefit from the work that we do to help improve outcomes and change the future. So with that, I want to sort of think about activating us, because I think a lot of times when we talk about communities and community engagement, we're talking about partnership and wanting to do work. But I actually think we need to take a step back and really get curious about some groups, some people, some institutions, even my own, and I'll use a lot of exemplars from my own life, my own work. We have apologies to make. We have truth and reconciliation to do. There is some of that foundational work isn't just creating trust and partnership. Some of it is actually laying the groundwork for future work. And that in and of itself is valuable. I always do a land recognition. We do it at the University of Washington. This is where we currently are. I am not naive enough to attempt to pronounce these, but I will go to the landacknowledgement.org if you don't know it, to be able to understand how to speak these names. As a Black identified American, I also need to make a land and a labor acknowledgement, because I think it's really important for us to acknowledge, and this comes from Seattle King County Public Health, that it's very important that we understand how we got where we are. We're lucky that Professor Dawes is in the room, as well as Dr. Guillermo Ramos, who have given us some historical understanding of things. But without acknowledging the labor, not just of how we got here as a country, but the labor of the people who continue to do the hard work throughout the nation, I don't think we're going to get anywhere in terms of wanting to improve any kind of outcome. I also stand on the shoulder of giants. I came in on Tuesday. I've been attending the Congressional Black Caucus Foundation meeting in addition to stopping here. If you don't know Frankie Manning, and if you don't know Dr. Betty Smith Williams, I highly recommend that you look up their work, because the two of them are two people who both are living, who inspire me to do the work that I do. So some of you may not know me, and I wanted to make sure that you had a clear understanding, whether you're watching virtually or you're here in the room, that it's quite possible to have a very successful research program and trajectory without ever receiving federal dollars. And this is really important. I say this not as a slight or a ding, but you will recognize, even from the previous presentation of research, foundation grants, intramural projects, small grants, professional organization grants have historically served as the foundation for people to get to their first R01 or their first R21. So I want us to start thinking really creatively around the fact that we can also be thinking about who are those other communities, who are those other funders, who are those other stakeholders that we need to be thinking about in partnering to really develop nurse science scholarship in health equity, because those have been very, very crucial to my career and probably to many other early career folks as well. I have been a highly successful and prolific person because of the communities that lift me up and that I am in, with, and from. And I want us to start using that language when we talk about community engagement, right? Because it's one thing to be in community. It's another thing to be from a community. It's another thing to work with community. And it's another thing to be of community. And those things matter in terms of when you're building out programs of research and trying to design interventions. Dr. Ola is a Black trans woman who is a statistician by training and is finishing up her medical degree at the University of Pennsylvania. I've heard a lot of talk about health equity. I use Dr. Kamara Jones's definition of health equity, which is the assurance of the optimal conditions for people to achieve good health. I also like to give people definitions of anti-racism, and there are more than this one, but I think this one is really, really important. And we've talked about the relationship between health disparities and health inequities and health equity. And I want to introduce anti-racism definition because you will see it actually is very aligned and congruent with what we're thinking about. The way that Dr. Lett describes this, she says it's the continual practice of unlearning internalized belief systems dictated by white supremacy, redistributing power, resources, and privilege to populations directly and disproportionately harmed by white supremacy, and redressing historical and contemporary biological, mental, spiritual, and social injustices enacted under white supremacy. I love this definition because it's action-oriented. It's not like theoretical, and it's not aspirational. It actually speaks truths and is very directive, which I think is something we might want to start thinking about when we're talking about what I think is the unethical continuation of contributors to premature Black, Brown, Indigenous, and other people's deaths in this country. I already talked about one definition of health equity. This is Dr. Kamara Jones's. The second one, though, I really want us to pontificate and ruminate on this. What if health equity is experienced? What if it's not achieved? Right? What if it's a continual experience of the people that we serve, or the populations, the communities with whom, from whom, of whom we work? Then who gets to decide what that experience is? And how would we measure it? How would we start to really understand that somebody's experience has changed? I love the previous presentation around the food trucks because they are constantly looking at not only consumer data, but they're also looking at utilization data, right? And how does that change over time? Because at some point, if those people are able to get meaningful work at a living wage and they get employer-sponsored health insurance, at some point you would think that the residents wouldn't be using food trucks anymore, right? Is that how we're thinking about this? Because that's how I think about these things, right? So what if health equity is experienced? So what will it take for people to have an experience they would actually recognize as equitable, right? I want us to be thinking differently when we start to think about our work. So let's deal with the elephant in the room, right? We've had several publications around the shifts in nursing science. We're at a precipice, right? I mean, we have a situation where we have multiple pathways for advanced education in nursing, and that we see a huge brain trust in our doctorate of nursing practice individuals, right? And we're starting to see a drain. I mean, Sean Clark just had a piece in Nursing Outlook about this, about where's the future of the PhD researchers, the researchers and knowledge producers, right? Like, we need to wrestle with these things because that's our future brain trust. So until we can clarify that, when we come into communities, it is confusing to them when we have shared credentials and different skill sets, right? So maybe we need more data visualization problems. I love the fact that the NACNR report has infographics and a whole variety of other things. Maybe we need more interactive tools to engender or garner that trust that we're looking to restore. I won't even say build, but to restore. So we need to have these conversations. And I'm actually really glad. I would like to see more publications and conversation about this. I will put my hat on as the editor-in-chief of Health Equity, that you are going to start to see some really fun and interesting product offerings. We need to be thinking more about our communities, not just faculty. I've heard schools of nursing homes, Dr. Atkins. Maybe we need to talk to our professional organization. Oh, and our publishers of science to also think about their role in building momentum around these upstream solutions that we need and the excitement that's necessary for us to do authentic community engaged work. So I said this in the hotel this morning. You may or may not have heard me say this, but I'm going to continue to say this. We're either going to apply internal pressure to ourselves around community engagement and authenticity, or it's externally going to be imposed on us. And I would like for us to be bold and courageous enough to be able to make the decision that we're finally going to spend some of the most trusted of the health professions currency in nursing. This is from my former home state, that's Governor Gavin Newsom. There were almost 20 bills that were signed into law. So we're in the Dobbs world now, post-Roe, where we have states picking up the mantle of training the next generation of reproductive health care workforce and other positions based in response to state legislatures, right? So that means, are we going to engage with and decide how those dollars are going to be utilized? And my answer is absolutely. We had PhD prepared midwives functioning to help craft some of this legislation to allow us to bring nursing leadership and work forward to be able to develop the workforce of the future, grounded in communities and centering communities where they have not had access or pathways built to the health professions. They are including not only community college, they are including high school interns. They are doing intergenerational cohorts of people so that we can have that representative workforce. When we think about the Sprint for Women's Health, when we think about ARPA, I'm so glad to see our Office of Women's Health Research folks in here, right? When we think about all the attention and the investment, how are we including communities in these opportunities, right? We had a watch party with the doulas when the Gender Policy Council, and I meet with Jen Klein every time I'm here in DC, to say this is what the federal government is doing to help improve our health, right? Maybe it's time for us to do more community work outside of baby showers, right? Maybe it's time for us to have watch parties around what the people who work for us are actually doing on our. This is going to be very fascinating. So I don't know how many people saw Melinda Gates's op-ed right after Memorial Day, how she's going to invest $1 billion into reproductive women's health. Okay. So she decided to give $240 million to 18 organizations. Those 18 organizations are listed on the right. The purple arrows are people, myself, and a whole lot of other people know, work with, have on text, or are friends, right? Who in this room is prepared to go to those organizations with their unrestricted money and put those ideas in front of them about partnership and working with communities? That's the kind of external pressure we're going to start to have to think about. 12 individuals got $200 million, $20 million apiece, to be able to unrestrictedly do incredible community engaged work. Well, Allison Felix happens to be one of them. She's on her way to Black Mamas Matter Alliance meeting right now in Atlanta to talk through working with those community-based organizations should be doing around maternal health. And my question to her and to Black Mamas Matter Alliance, full disclosure, I used to be on the board and was the board secretary. How are we connecting with the Improve and the Compass initiatives here at NIH to create a seamless pipeline of the work that we're doing, right? How can we have bi-directional communication that's not burdensome, right? To Dr. Wang's point earlier, I'm gonna get to that, right? How can we build essential infrastructure to make sure that capacity is there for meaningful and authentic community engagement, right? The Levers for Change MacArthur mechanism is how she's going to release her request for applications, and they're supposed to be coming out this fall, right? How can we prepare NINR funded investigators to be competitive? How can we be thinking about incubators and accelerators to help us to really be able to put our leaders in place along with shared community partners? Because I think NINR can do this, right? We can fund investigators and community partners, similar to what Robert Wood Johnson has done with interdisciplinary research leader groups. It's fun teams to be able to competitively write for other kinds of applications, right? We could have NINR community fellows. Right? I'm pontificating here, but my job is to seed ideas and to activate you all to think differently about how can we consistently, authentically, and meaningfully engage with community and communities. So if we're going to map the future, in my mind, and you've heard a lot of this from the NACNR report, and yes, I've read a good amount of it, and I was on the NINR webinar because I am so excited by that work. We have to think about the retrofit, which is the future workforce, because at some point, I don't want to continue to be the lone Black full tenured professor wherever I am, right? I want there to know there's 10 of them, right? And know who's coming up through that pipeline. So how do we get there? The reform is community engagement. We will not achieve health equity. We will not reduce health inequities. The mechanism through which we reform is authentic and meaningful community engagement. That's also, here's the dirty little secret that nobody wants to say, it's also the access point for sustainability, right? When communities own these initiatives, when communities own and have a stake in the work that we're doing, this is one of the things that doulas have taught me. I remember when I started my doula work in 2013 and we had our project piloting doula support for incarcerated persons, that we had to explain to people what doulas were, right? Now everybody talks about doulas, right? That was a concerted effort amplifying doula voice, explaining to people, listening parties, watch sessions, bringing in doulas to be able to talk about the essential work that they do. That was a strategy that we can also deploy with community members with lived experience. And then the reimagine is a community investment. We heard Professor Dawes talk about investments, right? That came out of Heckler. We're still waiting for those investments. One of the things I've been sitting and wrestling with, and I saw some of you on the break around this, is I worry that by addressing social needs within clinical and health systems and medicalizing social needs, that we undermine our argument for a robust social safety net. I worry about that, and I want us to wrestle with that because community members recognize robust social safety net. People can tell you what nurse-family partnership is, right? People know who their home business are because they're not coming into the health system, they're coming into communities. How can we think about this? And I love the fact that this is a strategy to get people's needs met in the now, but restoring basic social support is going to be crucial if we want to achieve health equity and decrease inequities. When we look at different countries that have superior health outcomes, they have a robust social safety net, whether it's paid family leave, parental leave, whatever it is. So at some point, we have to add human services to health. In my own research program, I was saying this at lunch, I think it's really fascinating. I came here intramurally as a laboratory trained bench science researcher. I still do oncology work, right? Yes, because development, whether it's tumors, fetuses, socially constructed, it's very similar to racism. We can have a long conversation about that, right? But I do biospecimen, biomarker, survey, qualitative research across the reproductive spectrum. We need more scholars training programs, fellowships, opportunities. I would love to be able to have a community partner, not just as a co-PI, but as a co-trainer on our T32s, right? We are experts by education. Community members are experts by experience, and we should fund them as such, right? When I think of, so what do we need? I could give you all the whole list, and I hope we're going to generate one together because we're going to do an activity called I Like, I Wish, I Wonder, and we'll get to it in our conversation. But we need, there are data gaps. We talked about this in the NACNR report, right? Meta-analyses and pooled data. When I think about Abigail Echo Hawk, and when I think about our Native Indigenous colleagues, and they talk about data erasure, there were methodologies. We just required people to put their small counts in their studies. By now, 20 years later, we would actually have accurate population estimates of different conditions and how they show up in those small communities. We have to be proactive now in making decisions with communities to decide what data elements we want in the future. I would have never known that community members wanted ancestry data when we came out of our registry of, we did a study, a cohort study looking at preterm birth and looking at environmental factors around that. And when we talked about remuneration, what did you want? What did you want? Community members were like, I'd actually like to know what part of Africa people immigrated from because I don't know. Who knew that providing people ancestry data was going to be more important to them for remuneration than it would be for money? But we had to ask them that. We had to talk to them about that, right? I'm not going to go through this full list. I will get to the bottom though. Truth and reconciliation, we have to start funding, whether it's, federal funders, whether it's philanthropy, whether it's individuals. We have to start using the language of truth and reconciliation. We really want to build trust. Not everybody can do community engaged work because you have to apologize for past harms, either of research groups or the institution where you work. And that work in and of itself is valuable as far as I'm concerned, right? When you look at the historical harms of research, maybe your community engagement is actually an apology. I currently hold the oldest and the wealthiest endowed professorship at the University of Washington, which used to be named for its founding dean, Elizabeth J. Sewell. We renamed that endowed professorship because notoriously she barred Black students from attending the University of Washington School of Nursing. That resulted in an apology from the mayor, from Dean Woods, who is a longtime mentor of mine, and a name change of that endowed professorship because the Mary Mahoney Professional Nurses Association, who received that apology, requested apology, right? That was important work that needed to happen that built trust with the Black nurses in the Pacific Northwest and Seattle. We need to start funding that kind of work if we're really serious about building a strong foundation for the future, so that we're not sitting here 20 years from now still looking at inequities. I think we also need, so I'm gonna put my AI hater hat on, and because I'm very skeptical about AI, to Dr. Guillermo Ramos's point around reifying inequities and reifying bias and harm. But I will also say that we can be more creative than AI because we create AI, right? I don't want to lose the human capacity to be able to be generative and to be able to create, because we are so contingent upon artificial learning for generation of actually creative solutions. And that's the other reason why we need to be very careful with authentic, meaningful community engagement. When we bring brilliant people together around a shared goal, that's when magic happens. And I don't want to see that get lost because we're trying to shortcut the messy work that needs to happen among and between humans. I also think we need to really start thinking about institutional review boards and their role in stifling innovation and partnership. I don't know about you all, but I spend a lot of time rationalizing to my IRB why community members need the role that they need, why I need to compensate them, the levels that I need to compensate them at. That's a structural thing that we can fix so that community members don't feel like blindsided when we've gotten our grant, we're ready to start our work, and we can't get past our feet because we're still using concepts that I think are dated around protecting institutions and not individuals. We need a community-based set of principles around IRB. And Harriet A. Washington has wrote a really great book about this. So we want to be thinking, what are the structures that we're currently using that are actually reifying community mistrust? There are two community IRBs that I know about, and they're both run by Black women, and I think it's really important. They have a whole different set of principles when you think about things like community data use agreements. We've written several. Well, what does community-based participatory budgeting look like? How do you work with community members to put your budget together? Right? This is my classmate, PhD classmate, who now is at the University of Massachusetts Amherst. She's a sociologist, Dr. Irene Martinez. She wrote an incredible set of papers around what is the process that you go to when you're trying to develop a community-based project research budget with community members. What are we as investigators not thinking about when we're trying to do community engaged work, right? Or what does data use agreements look like, whether they're de-identified or not? Do community members get their own dashboard? How are we thinking about data dissemination and data visualization? Can they make their own graphs? I was actually really stunned to see graphic renderings of research data that I collected during the pandemic with a digital scribe show up at a city council meeting in Memphis, Tennessee, because we had images that represented data, right? They had one pagers made and held them up at the city council meeting of our shared research project. Because what like creativity of nursing can we be unleashing? Things that we know about our shared work, about the theoretical underpinnings of how we actually think about care. We could unleash so much creativity if we had the practice and play space to be able to do so. I also want us to start being really mindful of some things that I think are incongruent with like inequity and health equity. We need to think deeply about how we measure proxies and why we're using them. My good friend, Dr. Joy Perry, who will be speaking at the Congressional Black Caucus Foundation meeting tomorrow, she taught me this. You know, marital status is really tricky when you're talking about people with low incomes. Because if you have two poor people who come together and marry and then they have a child, now you got 3 poor people trying to live on the income that 2 previously poor people couldn't, right? The math isn't mathing. So we need to start thinking, what are the other kinds of data that we could be collecting? We have to start thinking about human, money, space, time, reputational resources, right? I mean, Professor Dawes talked about that earlier. How are we leveraging those, right? I can't tell you how many community groups come to me to reserve space on UW's campus because they know I'm a faculty member and they can get it for free. Maybe that just needs to become a thing as part of authentic community engagement. right? If we're going to be funding fellows who are expert in community-based, work, maybe they have monies to be able to bring in community partners so that community partners can plan their own work, whether or not it is part of a specific research project. And then community oversight and review. I'm about to implement a really crazy thing at Health Equity, and I'm really excited about it. We're going to have we're going to pilot a community review board. We're going to ask, and Mary Liebert is working with me on this, we're going to have lay summaries of all scientific abstract, and we are going to pay 20 people to do peer reviews of the lay abstract. And we're going to put the lay abstract with the scientific abstract, and then I, as the editor-in-chief, are going to make a decision. Okay? We need to pilot funding community review boards of our science, because then they have an invested stake in how that's disseminated, how it's analyzed. They can talk about the project because they've read it. Their name will be on the website as reviewers, right? I mean, so we need to operationalize what we're talking about, and that's part of my job. So I Wish, I Wonder is a tool. I'm going to end on this, where I want you to think about, what do you like about what you've heard today? Regardless if it's from me or any of the others. What do you wish you knew about what we've said? What do you wonder? I'll give you mine and then I'll end, just to get your mental juices flowing. I like that communities know what they need. I like that we're finally having a conversation about zero-sum game and how it's false. I like what I saw about Compass because, full disclosure, our institution is a Compass applicant. I like that we are having very new and interesting conversations. I wish that we would fund truth and reconciliation efforts. I wish that we could fund rupture and repair, almost like tribunals. I wish we could learn more around that process from our international colleagues. I wonder about this policy integration of clinical and social care. I wonder how we can better partner with and have co-PI, community investigators, experts by experience. And I wonder if we will have the courage to do the important, hard work that needs to be done. I'll leave you with one slide, which is one of my favorite photos. You will probably recognize some of the folks in this photo. We decided to come together at Worcester Kluwer's, and I love Carl. He really pushed AJN, our flagship nursing journal, one of the oldest, to think about what does equity and peer review look like? How can we start to ask journal editors, associate editors, and reviewers to be concretizing everything you've heard today in our work around science that we publish? And I don't think we've paid enough attention to understanding that record that lives in perpetuity is also a roadmap for us to think about how we might want to better partner with communities and to bring them into the scientific enterprise to help us not only improve health outcomes, but to get closer to health equity. So I hope this is helpful. I hope that you've been activated to really start to think differently about what you like, what you wish, what you wonder, because if we as individuals can be able to get to that, and collectively, we can have a shared strategy to communicate to the rest of the communities and the constituencies that are interested in the work that NINR is doing to allow us to amplify our role as leaders and strategizers in moving this work forward. So thank you for listening, and I really appreciate it.
Thank you very much. You've given us a lot to wonder about, and we're going to keep wondering as we transition to Dr. Knight. And then we will engage in discussion with both of our speakers. So Dr. Knight is the Sarah Frances Russell Distinguished Term Professor at the University of North Carolina, Chapel Hill School of Nursing. Her program of research focuses on the social, policy, and economic determinants that impact the health of disadvantaged populations, particularly in relation to welfare policy, employment, and women's health. She is the past chair of the American Public Health Association Public Health Nursing Section, serves on the editorial board of the American Journal of Public Health, and is completing an NIH-funded clinical trial testing a multi-level intervention with unemployed and underemployed adults who are socially and economically disadvantaged. Dr. Knipe will speak on strategies for moving nursing science upstream to focus on structural social determinants of health. So welcome, Dr. Knipe.
Thank you. It's really a pleasure to be here today and talk to all of you. And it looks like I might be the last person to help you wonder about things, and then we'll get to talk about them. So I am going to be focusing my talk primarily on how we can encourage upstream structural orientation in social determinants of health focused nursing science, and hopefully bring some very pragmatic suggestions to the table around this. Just an overview of what I'm going to talk about, thinking about health inequities or health equity, and the causes of causes, and what I'm beginning to think about as third order causes. And we're very familiar with some of these in terms of behavioral, biological, social determinants of health, structural, whether it's upstream, whether there are things happening outside the healthcare institutions and why that needs to happen, and across sectors. And then really for us to think about how do we encourage a social or a structural social determinants of health prism development in nursing science where nurses and nursing scientists are. So in terms of a prism, you know, how do we get to see what's out there? And I'll show a little bit of data around that. So in terms of language, other people have talked today about just how important language is, and it's critical. This is just one schematic for thinking about social determinants and at what levels these things are functioning. Starting with the blue level in the middle, I think we're all very familiar with the top level and the overplay that has had in our understanding or attempting to understand why there are health inequities. But thinking about the blue level here, the conditions in which people live, work, and play. And Paula Braveman talked about these as the causes of causes. And these things are functioning in families, workplaces, healthcare clinics, schools, you know, programs, social services programs, some of what we've also heard talked about a little bit today. And then there are these third order causes, which Professor Dawes and other people have started to write about in terms of the commercial determinants of health and some of the other things that are going on at the national academies in terms of looking at economic structures as drivers of this. So these are all this is one schematic in a way of thinking about what maybe the fundamental causes are in terms of structural issues. And one of the things that I want to point out here, which I guess my mouse does show, is the article that's recently come out by Heller and colleagues really talks about power dynamics and much of and the important role that plays, but sort of its invisibility in a whole lot of this. And so a lot of what I'll be talking about focuses on that. And I do want to point out, I think this is a thread to keep in mind as I make some of my comments and talk through this quagmire of factors, but power dynamics play out at this level of the system structure, but they also very much play out here. And so if we think about power as one of the fundamental causes, it doesn't necessarily mean we have to be in the room where policy is made to affect that level of change, of addressing some of the power structures. We can be doing that in some of the places where you find nurses, and even what Dr. McLemore was talking about, in some of the spaces where we're already doing our work. So if you haven't seen this publication by Heller, I highly recommend it. They draw quite a bit of attention to structural features of social determinants. One of the things that they talk about is the WHO Commission on Social Determinants of Health, which is really quite dated now, but that initially defined structural mechanisms kind of in politicized terms, right, where social hierarchies were talked about and power and prestige and access to resources were discussed. They also make the historical point that when this was taken up, meaning a definition for social determinants of health by U.S. institutions such as the CDC and others, there was depoliticization of the concept. They attributed quite a bit of this to a dominant neoliberal worldview around what's possible or not possible. And one of the things that they did in this article was they did a review of literature and found this wide variation in defining structural determinants of health. Now, I'm not sure what happened between 2010 with the CDC and now, but CDC has now adopted the World Health Organization definition, which I think is really important. And NINR has a term here, at least, that specifically identifies structural determinants of health. So calling that out and not just, assuming that that's the same as other determinants. This is the Commission of Social Determinants of Health framework, and it's another way of thinking about this. And one of the things that you'll see that's different about it is instead of a hierarchical top-down kind of a structure, it points to influence from left and right. One thing that it does that I think is a little different in what Heller and colleagues talk about, and to take a look at that and read this very carefully, is that it equates culture and societal values with the policies that they produce. When what Heller really points to is that when they bring power into their mental model of this concept and talk about how power is exercised to in fact produce these things. So how we think about things, what we think is possible, the things that we don't question, the things we don't wonder about, all get automatically, written into policy. So the other thing that really struck me when I was reading some of these articles that I think we can take advantage of here in this moment for nursing science is thinking about the long causal chains of mediating factors. These tend to cluster and interact. That is one of the things that's in the WHO Commission. And it's just a good reminder that it's not just one mediator or two, but these are incredibly dense and complicated dynamic systems that are always changing. So how can we think about our science in a way that sort of does that credit? They do have this increased focus on power, which I talked about, but also how it operates within the causal chain. And again, when we think about that, we tend to think about who's in the room creating policy, but if we can think about that in different ways, we can think about how nurses operating in different environments might learn to see that and undo it as well, which will also do a lot in terms of health equity and how decisions get made and how programs are implemented and other things. Heller uses Stephen Luke's 3 faces of power, and I think this can be useful. There are other frameworks for power too, but one is decision making, which is sort of the obvious one that I've been talking about. The other is agenda setting power. Who sets the agenda for what can be even discussed or talked about? And then invisible or ideological power, which other folks have cited as the most potent of them all, which is, how we believe things that we don't even question, and we make these automatic assumptions. It's, the basis of implicit bias in many ways. This is, so I'm drawing heavily from Heller's article because I think, and I had to put this graphic in because I think it's one of the most important that I've seen. If you, and I know it's really tiny and very difficult to see, but if you look at the anchors of this continuum, essentially, these are interventions into the social determinants of health. And so, both anchors are the same thing. And this is a continuum. Toward the bottom, as the continuum moves upward, there's an increased impact on the distribution of power. And it's really the distribution of that power that sort of keeps things in motion and makes things very difficult to undo. So when you think about the kinds of interventions that really don't upset the distribution of power very much, for example, they're the kinds of things that are being readily adopted widely by nursing in terms of doing screening for social needs and maybe doing some voucher, provision for social needs. And this is not, I want to make clear, this is not to say that we don't need that kind of work, but the vast majority of our work cannot be in that bucket. We need interventions that go all along this continuum. So if you look at the middle of the continuum, for example, the example given is how we change laws about maybe land ownership so residents have more control. I mean, a lot of us, I think, might even consider that to be sort of one of the things at the top, right? But what they have at the top of this continuum is to change people's beliefs around housing. This just happens to be a housing example, about housing as a right versus a commodity. And there are a lot of parallels we can draw around health and access to health care around that. But it really gave me pause to think about how we've been sort of structuring our ideas about the structural determinants of health. Let's see, let's go on. I think I'm going to skip this example. So if we think about how to develop this prism for nursing, I think one of the first things that we really need to do is come to terms with where we actually are and have some radical acceptance on that topic in terms of, collectively, how far have we moved? How far has our thinking come? Where is the vast majority of nursing thinking around social determinants of health very firmly located? And that is at the very bottom of that continuum in the diagram that we just looked at. This photo or graphic here, for kicks yesterday, I Googled schools of nursing. And these were the photos that came up. And there's not much in there that suggests something different than acute care kinds of settings, acute care kinds of tasks, acute care, anything really. And this is just one little snapshot of what came up. So I have some recommendations based on where we are. I think we need to increase exposure opportunities to observe how social determinants of health operate for nurses. There's some very specific things we can do about that. I think we need to deepen our theoretical understandings of power and apply less familiar but very well-developed methods for inquiry, bring that into our sphere, if you will. And this is more of a charge or challenge for our funding agencies here, which is seek ways to incentivize number one and number two through research funding opportunities. So this is data from 2018 about where nurses are employed, where are RNs employed. And if you look at this, the very small, these two slices here are basically outside of what we would think of as clinical settings. Okay, that's like 3% of nurses. And that's actually quite on par with, this drop in public health nursing workforce. And I'm not suggesting all nurses should be public health nurses. That's not what I'm saying. But if you're looking at a segment of nurses who are practicing in communities, hopefully with communities, like we saw from our North Star example here and her food, I want to call it a food truck, but it's her mobile grocery store. We can see that, but this has precipitously dropped to 3.2% from 3.2% in 2000 to only 1.4% of the U.S. workforce. And this is a slide. It's busy. I don't expect you to look at all of it right now, but this is from a talk that I gave at the National Advisory Council on Nurse Education and Practice a couple of years ago. And at the time, I just wanted to map what was going on sort of nationally and in public health very generally, and then specifically in the nursing profession during these different time periods, 2008 to 2016, and then to the present. And if you look at any number of these things, they are in direct conflict with one another, and they are happening at the same time. There are recommendations from the second Future of Nursing report about how we need to move into the community. There are recommendations from AACN about placing nurses in non-traditional kinds of settings to do their work. There are recommendations left and right like that, but we've seen virtually not much of anything happening there. If anything, we've seen perhaps more people going into primary care settings that are still fundamentally clinic-based settings. So we still have, thinking about internal, external pressures, we still have these very significant external pressures, like basically positioning nursing practice based on economic models and healthcare financing models that will keep them there unless we are able to apply pressure from the inside out. One of the things, that I talk about with my colleagues quite a bit is, so what does nursing have that is unique? What can nursing bring to this effort that isn't duplicative or can't really be substituted by someone else or a different discipline? And I think, one of the things that I think about is nursing has clinical knowledge, and we are there. There's this intimacy that we have with the people we serve and take care of during life's most sentinel moments. These are moments of joy. They are moments of absolute, horror and sadness, and we have a public trust. One of the things that we can do, while we need nurses operating here, perhaps, in Congress, et cetera, of course we do, there, I think, is much more opportunity in these locations where programs are actually delivered, and schools, workplaces, other sectors where nurses have not traditionally been, but I wouldn't say haven't traditionally been, were a long time ago with the origins of public health nursing, were repositioned into more acute care settings. And how can we go back to those places? And I'm not saying that's a place to stop or that will have solved everything, but I think these are the places essentially where if we can position nurses to be in those locations, that's some of what gives you this prism. It's some of where you see these inequities in action in ways that are outside the health system. And I'll talk to you a little bit about that. I think I'm going to skip through these slides because I know we're a little bit behind, but fundamentally these slides are saying like, ooh, where are the nurse scientists? Oh yes, many of them or most of them are in academic research institutions. So we'll just sum it up that way. So this first recommendation, I'm basing a lot of this on my own experience in, sort of doing research on social determinants for a really long time. And one of the ways that I was able to develop a prism like this is by being embedded in the community and being embedded in social services programs that serve communities. One of those programs was the Temporary Assistance for Needy Families program, or TANF. And, I did this work for 10 years in a particular community in Florida where I was able to take public health nursing students and provide services in these communities, with these communities, and develop interventions with them. This intervention, we tested, it ended up being incredibly effective by basically taking nurses out of where they traditionally function and putting them in the spaces where people were. And there was a very specific need for this. And some of what we did there was very specific in terms of what nursing knowledge we could bring around existing health conditions versus trying to place women in particular kinds of jobs. And there was often a mismatch there that went on to do more harm for the women than good. And this was a space where nurses could actually make some change and see how the functioning of that program, for example, was doing some harm in ways that we could quite easily remedy. It didn't fix everything about that program, but it was able to do some good. So the second sort of stage of my research has been in North Carolina, where, I took what we did in this TANF program to the social services agencies that my partners that I began working with in North Carolina, where we were providing services for them based on evidence that functionally helped them do their jobs, right? And they understood that. They understood this was good for the clients. They understood that it allowed them to focus on what they needed to do rather than dealing with something they weren't really equipped to deal with, which were kind of the health conditions that were getting in the way. This took a whole lot of time and effort, and you heard from Dr. Warner talk, about this, but there was deep reciprocity in relationships that needed to be built during that time. This was all quite dependent on my School of Nursing administrative structure allowing me to have students to take into those settings so that I could be there. I was a constant presence. And it was not something for a very long time, things were able to function in that way. So I wasn't just in and out based on the school's convenience. I was in it for the long run. And I was given, some, promises that I would be able to stay there in the long run. That ended up being incredibly important for us to then move to the next iteration of what we thought we needed to do in this program of research. And I'm not going to talk about this specifically, but no, that was done. It couldn't have happened without that deep building and my presence in that location. So that's the first thing, is how do we create opportunities within predominantly our academic structures so that our nurse scientists can spend time in the communities that they need to be working in. There are ways to do that incredibly efficiently with students and meet the educational aims, meet the service aims, all of it at the same time. And but largely that has been an internal pressure sort of mechanism and dependent on, kind of who's at the helm and if that's allowed within a particular school. The second recommendation is to think about how can we deepen our theoretical understandings of power and apply less familiar methods for inquiry. And here, a couple of things come to mind: critical discourse analysis and historical analysis. There were a couple of papers. This is a series of papers. This was a research project that was completely unfunded, that taught me more about power than anything I think else that I have done, in terms of, looking at, we used Foucault's framework and looked at how was it that the future of nursing processes were shaped or were constructed to sort of formulate an outcome, right? And how was power threaded through that, and what can we learn from what happened there? One of the reasons I did that, that analysis, was because we were very, very concerned. I was chair of the public health nursing section at the time, and we were very concerned about keeping the level of thought of social determinants at the level of social needs screening and provision in acute care settings. So point being, it's not what's in those articles. It was the methods that we were able to use to get at some of that. There's a similar example by Megan Ming Francis who used historical analysis to look at the price of civil rights and movement capture, and how different funding and funding agencies essentially constructed over time the agendas and the focus of the NAACP and what happens there. And I guess, I'm adding this graphic here just to show that there are ways to extract quantifiable data in some of those methods that we can be thinking about. And the reason this is important is because how this plays out in every setting really undergirds the political, commercial, and economic dimensions, and undergird how these policies that we so desperately want to put in place, what they actually look like in terms of being delivered on the ground. And that's where I think nursing has a lot of potential leverage. I think I will skip that. This is the third recommendation. And, that is, how can funding institutes like NINR incentivize recommendations, those kinds of recommendations? What shape might these incentives take? And are there other entities that can facilitate those kinds of incentivizations within or external to schools of nursing in the places where we find most nurse scientists? So I will end my comments there as my part of my research team, and I guess we'll open it up for discussion.
Thank you very much, Dr. Knight, for adding those additional things for us to think about as we move into our discussion. So we did send council several questions in advance of the meeting to help us reflect on NINR's future role in terms of advancing health equity through research. The goal for us today is to talk about bold ideas, innovative solutions, and big goals that NINR can, again, help to advance towards these goals through research. So I've asked Dr. Wang to help lead us through discussion. Thank you.
Thank you. I think I'll start with answering the question of Dr. McMorrow about, what I like, what I wish, and what I wonder, as all of you are getting your brain juice together to really think about what's the next bold idea NINR can lead, and what can we do? What are some of the out-of-box thinking? And starting with, I see hope with all the presentations from just Director Jen's report to the all of the presenters today. what I really like is I really like all the work that has been happening. What's happening right now, I like all of that. And I wish health for everyone everywhere. And I wonder, given what we have done over the past 20 years and what we have learned from the report, Dr. Gilmore Ramos has presented to the nursing community and provided some of the strategies. Exactly what can we do through the next maybe 40 minutes of our discussion? How can we provide some concrete suggestions, observations, and to lead, to offer our opinions for NINR to really lead the next phase for the 40 years to come, so that we demonstrate our community, nursing community, will not accept a continuing lack of progress 20 years later when we look at it, and how can we move that needle forward. I want to start with sort of what we have learned from Dr. Guillermo Ramos about the strategic opportunities in nursing to lead in eliminating health inequities. What kind of innovative health and healthcare delivery models that nurses can lead, and what kind of science evidence that we need to generate, and how it ties with the scientific workforce development, such as a nursing school should be doing at different levels, not just in generating the nurse scientists in a PhD program, but also maybe starting from undergraduate program through some of the community partnerships. And also I want to reflect about just our Deputy Director, Dr. Eklund, talk about health equity being NINR's North Star, and sort of we have all of the mission in action that we have heard from Dr. Horning, and also reflecting about our current top ranked in funding behavior and social science and funding in health equity. As we are reflecting about the fundings and the evidence that has generated, what is the power in NINR and nurse scientists in bringing these evidence that are already generated and what yet to generate to amplify the voice to the community, back to the workforce development, back to the scientific workforce development. So we do not want people to reinvent the wheels, because it's really important. We have done a lot of work. Why are we not moving forward? Are we recreating work? And how can we make sure that we accumulate evidence and we go step further every time, learning from others in this evidence generation? And I appreciate Dr. Horning's presentation. I really love our question and answer, kind of advancing science in the real world evidence and the rigorous research, right? That's what we hold near and dear, but it really should not prevent us from thinking rigorous research can only be done in certain ways, and how to partner with the community and the communities, that how can we really advance science, knowing that the real world is not as simple as a very well-controlled randomized clinical trial. How do we even need to advance methodology? There are a lot of methodologies that are out there right now, and AI tools and all of that informatics tools that are out there, that probably we should extend our horizon in looking at our methodology as well, that can marry kind of the rigorous science and also the real world evidence. And what can I say? Amazing researcher, Dr. McGuire. I really admire your research. And I think what I have learned from you is that really, I like how you say about it's in, with, from, and of the communities. And I love your example about bringing one of your mentors, founding president of the National Coalition of Ethnic Minority Nurses Association, Dr. Betty Williams. And she's also a role model of mine, kind of having worked closely with her, is when we define the communities, the federal funders, the foundation funders, how can we also not forget about the professional organizations, maybe also that have the nurses that are really laying the groundwork for health equity before the health equity becomes a buzzword. And how can we ensure the basic and social safety net and the infrastructure? And also, how should the federal government and funders look at truth, repair, reconciliation, and transformation? And I really love the fact that community engagement sometimes can be a simple apology. And that's a critical component of community engagement we can all learn from. And how can we emphasize the human-driven AI, that we created AI, what can we do and learn from it, and also the value of the community data, use agreements and participatory budgeting, visualization, and in moving forward in science, and also about the publication. How do we ensure equity in peer reviews? How do we generate this science and publish and dissemination this science? So I really, I do have a question for you, but I'll save it in the end, because I think it's really key to really, when we think about even funding research, how do we translate it into policies? And I think that's a critical component where I think out of the box idea will be is what should we think about at the funding stage? In making sure the research that we fund will actually be translated into policies that will bring permanent impact to the community. And also partnership about maybe we should partner with some of the foundations that are doing the truth, repair, and transformation work, such as Robert Johnson Foundation, right? I'm really proud of the impact investing. I mean, I have a conflict of interest serving on the board at RBJ, but that impact investing that are creating endowment to community-based organizations that will perpetually fund those organizations to deliver the work versus giving grant work that will stop in 1 or 2 or 3 years. And also think about PCORI as a funder that has successfully funding over that many years about funding community co-investigators. And how can we partner with these organizations? And what can we do at NINR in leveraging these kind of partnership in moving the needle forward? And of course, lastly and most importantly, Dr. Knight, and really appreciate your continuity of from social determinants of health to structural determinants of health. And also, how should we think about maybe we should bring back the community-based and public health nursing? Maybe we should actually, some of the social care principles and public health principles be the foundation learning for nursing and nursing workforce. And I just have to type, and I'll remember this when I give students orientation all the time, is clinical knowledge, intimacy during life's most sentient moments, and public trust. And how can we marry all of those in thinking about the nurse scientist role? And I have been thinking about, even just in healthcare, how can we incentivize people to work in primary care, not going into specialty? So how can we incentivize people to work in public health nursing community? Should it be marrying, what's more innovative out there in marrying the community-based public health nursing with AI data science, which can kind of make it more equalizing what these community and what these roles can make a transformation, kind of competing with the acute care setting. So I will end in kind of sharing my perspective. I look forward to hearing from all of the other council members, in hearing what do you have, what are some of the bold ideas. But I will start with this question for Dr. McMorrow about what's your secret in turning research evidence in policies? And what would you advise in our NINR if we are going to design funding research we need to make sure those research evidence need to transform policies? What will be your recommendations?
Well, thank you for the question. I have to shout out the logos on my first slide are organizations and institutions I work with. And Advancing New Standards in Reproductive Health of the ANSWER program at UCSF is the only one I remain affiliated with at UCSF, because their direct goal is to train researchers into how to translate their work into policy, not just to conduct good scientific, rigorous research, but to actually have the wraparound services that are necessary that are not taught in most schools of nursing, whether it's media training, understanding how to reduce complex scientific findings to really great bullet points. Like it's a skill that can be invested in and taught. So there's no magic to how I think about my work. I also spend a lot of time with congressional staffers, educating them about these issues. One of the things I find when we get really bad policy, it's because people don't understand the unintended consequences of the policies that they are either enacting or creating. And so you got to spend a lot of time with staffers, getting them to understand the science, the pro-science, and the sort of null studies, because that's the other thing as a journal editor I'm starting to really think about. We have skewed views of what's possible because we only publish significant findings, right? And that I'm starting to really think that is a gap in understanding policy, because we could learn a lot from null findings and translation into policy if we knew what worked, what didn't, and why. But you can't know that if it's not in the published record, right? So it's really more questioning the fundamental tools of science that we use to create understanding and knowledge generation, and then being able to explain that to another human being, which AI won't teach us.
Thank you. Can we hear some of the other council members? Feel free to.
No, you go.
Okay. Well, I want to thank everybody that's presented today. I think it's really been a great conversation. And Dr. Wang and Dr. McClure, I want to thank you for ending on policy, because exactly what I wrote down was, the community engagement we've been talking about is where you're going to find out the needs and the solutions, but it's not going to be sustainable unless we're going to be able to translate it for the policy to policy. So I think there's another level of policy engagement with the professional, professional organizations, policymakers, CMS, whoever it is, based on the problems that you're looking at, that we should be, for not all research, but for a lot of research, bringing it to that level. And that's what will be sustainable. So I love the conversation today, and I love the fact that it is going to policy. So thank you.
So it all came together to me with Sean, your last presentation, because I think there's a through line between the presentations that we had today. I mean, Vincent started off, we had started thinking about this meaningful community engagement. And I think there's also the same thing in the other conversations that we had. But one of the things that kind of came out was also this idea of rethinking philanthropy. I mean, and there is a critique of philanthropy right now, we kind of touched on a little bit, but this idea of strategic philanthropy and moving to this empowerment philanthropy, where we give the tools and the opportunity of communities to come up with their own solutions. And then I think it's something we've talked about in this room before, about thinking about how we think about our blind spots and who we're missing, and how we get communities engaged. And I'm really glad that that you brought up what the foundation, Dr. Wang, what they're doing around thinking about putting endowments in and giving the communities the tool, which is a real shift. But I mean, one of the other things that kind of came out, and maybe it's just my bias, we're also talking about nursing school and the opportunity that we are under leveraging with nursing schools, of thinking about how we start to transform that and create these opportunities to, as again, going back to, Dr. Guillermo Ramos's earlier talk about this workforce, right? Nurses are the biggest share of the healthcare workforce, and we should really be thinking about how we, again, kind of go back to where we started out. We started out in the communities, and that kind of came out in both presentations, and we should be going back there. How do we do that? So it's a lot, but I mean, it was really kind of like really brought it back together, Sean, when you your presentation just for me, think, okay, there's these themes are coming out of this, and how do we really kind of think that? So it's exciting, and I appreciate all the presentations today, because it really has my brain kind of like lighting up a lot. Think about, all right, what can we do here, and how are we doing this?
Can I make a response to that? You talk directly. You go ahead.
So, and maybe it's the same thing. Maybe it's the same thing. I don't know. But one of the things that I didn't really get to focus on just because of time in my presentation is, there are models of power that work on building on positives, right? Developing agency and coalition building. There's been a whole lot of discussion about coalition building and what that gets you in terms of communities being able to write their own future, essentially. And I don't know that we have really great empirical evidence of what models are best for training coalition building in communities under different sets of circumstances. But those are the kinds of projects, like if we understood what that process should be, we could, think of train the trainer kind of things, but we'd have an evidence base for it. We sort of know what works. I just don't know that anything has really been empirically tested in that way. So, that's a positive sort of very specific outcome that you could use a framework of power, to generate that kind of science.
And we give, the philanthropy has a lot of power. I mean, $400 billion a year is in philanthropy, and there's a lot of reasons to think that is. Part of the critique is that philanthropy has taken on this role of trying to, in strategic philanthropy, think about how it's going to make these long-term solutions, which really hasn't been able to do. I mean, federal government has way more power and way more investment in that. And should philanthropy really be thinking about creating this multiracial democracy and putting its efforts towards that? To really kind of, again, to your point about the power, redistributing that power and sharing the conversations. And one of the things that you had in the third order structure is like prevent the corporations that are redevelopment corporations from being able to donate and be part of that process, because that changes housing policy. And so it's just so interesting.
Well, I want to say two very unpopular things because I think they need to be said. The first one is, I think in nursing and nursing education, I would like for us to really critique the role of employers. Like I always feel like where we work determines who we are. And that is always very awkward to me, right? I mean, people use modifiers like I'm a bedside nurse, right? Or I'm a X, Y, and Z nurse. That's really based on where you work, right? So I always tell people I'm a nurse. And I'm like, well, what kind? And I'm like, the kind that's licensed. Right. I mean, like, if I had to explain to people based on, like, sometimes I'm a laboratory bench scientist, sometimes I'm a public health nurse, like, it makes sense in my mind because I'm a nurse. And so I think we put too much emphasis on employers, and that drives how we make decisions about, the kind of investments we want to make in nursing. But then the other side piece of that, which is also quite unpopular, which is I'm going to use my Dow professorship to try and create a situation where University of Washington becomes the employer of choice, right? If everybody wants to become the employer of choice for the future of nursing, you make very different decisions about what you invest in right now, right? So in my mind, healthcare reparations are when you start to really think about, okay, well, we're going to have debt-free education for nursing students for the next 30 years. You might very rapidly become the employer of choice, right? So I would like for us to trouble this discussion by trying to, holding the tension of opposites, right? We want to hold the tension that, yes, people need a place to work, and that needs to be a thing because meaningful work is very important. But we also don't want that to drive how we get at these recruitment and these issues where we can't have a workforce that looks like the people that we serve. And that's where I think we get gummed up. So to your point about nursing schools, as a nursing professor, I can tell you one of the reasons why I'm so public is to get people to appreciate that professorial life. It's fun. It's meaningful. You get to geek out with really cool people. Like there's a whole other side of nursing professor life that our future workforce doesn't see. So how are we supposed to expect them to then be excited to join us as the knowledge producers in our discipline?
So I just want to start by saying today's been fantastic. The last few presentations really opened, I think, all of our minds to new ideas. And so thank you both to Sean and to Monica. I want to go back to what I understood the question as being, which was NINR and sort of leading in terms of the future of nursing science. And so this may be an oversimplification, but I heard three things today that from my point of view really stand out as opportunities. I think the first is around settings and models. And at the very start of the day, we had some really terrific news about the NIH initiative around primary care. I would love to see nursing as really being instrumental to reimagining primary care. How can we demonstrate new roles for nurses, new models of delivering primary care, new settings that are locationally flexible? There's just so much there that could really transform our nation's health. The second thing that I heard was all the work that is happening around the development of the scientific workforce. And so for me, all the comments that I feel like Dr. Ayala was making around the rigor of our methods. And I'm going to keep that word rigor and not say that somehow the choice of the best design is not rigorous, but really emphasizing that we need to diversify the options in terms of how we think about rigorous research that actually should be used in terms of training, retraining all of us, 24, 25 years as a neuroscientist or as an investigator. And I still learn all the time. And I'm sort of very eager and hungry to learn new methods, new approaches. Ensuring that our scientific workforce is representative is another important area for the future. And then I guess the third bucket is what I have been increasingly sort of bothered by, to be perfectly candid, which is the invisibility of nursing and of nursing science and all of that means. It means, how do we elevate the contributions of NINR? How do we demonstrate that our contributions as nurse scientists are impactful, that they actually transform our nation's health? How do we ensure that nursing organizations and schools are actually doing the things that, you know, there's little evidence that that stuff is happening on the ground, even though sort of all the dialogue is occurring. I think those are all places where I would hope that the Institute could be a strong leader or a partner. I think that's really worth investing in. Thank you.
A couple of observations. One is as we talk about these issues and problems, one of the things, and Dr. Wang mentioned 40 years, looking 40 years ahead. The Stanford Center for Longevity released a report talking about longevity and how it's increased, and where we're seeing growth in the population is population over 65, 0 to 4 is decreasing. And so the Stanford Longevity Center on Longevity predicts that in the next 25 years, people over the age of 100 will be commonplace. And so how do you plan for that from the concept of research? If we're going to have a lot of older people, what are their days going to be? I mean, we're living longer, we're living healthier, but there will be more older people here. And if you're talking about 40 years, that's something that you may want to look at moving forward in terms of research. The other thing is Dr. Wang also mentioned PCORI, and I'm familiar with PCORI because I've worked with PCORI. And I think there was another mention of community engaged research. And that may not be what you do, but are there some aspects of community engaged research that you could look at and consider incorporating in the work you do? Because ultimately, the people that you want to help are the people that live in the communities across the country. And maybe there is a way to have some kind of focus on that moving forward. The last thing, and this is because I spent the last 12 years of my career in leadership, as a public official. I was assistant commissioner at Chicago Department of Public Health and retired as the regional health officer for the Illinois Department of Public Health. And one of the things that I learned about policy, particularly in a senior position, it requires rules and regulations, and rules and regulations can create structural issues and cause problems. So a lot of times people think policy is a solution, but policy can also create problems, because what happens is ultimately policy becomes rules and regulations, and there's some unintended consequences with policy. So I would caution people when they talk about policy to make sure that they try to the extent possible to eliminate the potential structural damage that may be caused by more policy and more rules and regulations.
Agreed. You need good policy, evidence-based policy.
Great. Any other council members would like to offer any opinions for?
Okay.
Yes, thank you.
I'm going to use your activity, Monica, to report in. I like the focus on the whole, but the term that was used was person. I wish we had a focus on whole family. And I wish we could change the way we deliver healthcare to actually reach the entire family all at once. And I wonder, and this really comes more from the Compass meeting than from this meeting, but there was a lot of discussion around care teams and the role of the community health worker. And the concerns I see there is that we've seen this in the past as they sort of train the important elements of a community worker out of them, or they place them in a context that no longer, they lose the trust of the community. So I wish we could develop more research around that. I know that there's a desire for a lot of research from some funding agencies about community health workers, but I think now that the focus has come around community engagement and people see them as natural leaders, how can we design more effective models that really can be sustained? Because I think we are contributing to some of the inequities because the individuals no longer start to represent their communities, so now they don't really have a place.
Thank you very much. I think everyone I can look at already spoken. I'm looking at this. I couldn't see you guys well. Any feedback, Professor Dawes or?
I know.
I'm forcing you. It's an important one. Next 40 years, right?
That is true. That is true. I would just ditto what has been stated. First of all, thank you both for your thoughtful presentations. I was taking copious notes here, and I heard Dr. Atkins talk about under leveraging nursing. I heard Dr. Guillermo Ramos talk about invisibility, and in my work in an academic health sciences institution, medicine and public health, it's fascinating to me when I heard both of you talk about increasing exposure opportunities to observe how SDOH operate, deepen the theoretical understandings. When you look at medicine, you look at public health, many of them are dedicating resources and attention at their associations, at their schools on these topics. So I totally agree that in nursing, in order to make sure that there is greater visibility, that we're leveraging the research, we're sharing what we find, I think now is the time to continue to lead from the front, not the sidelines on these issues. And I applaud you both for this bold presentation on the structural level determinants of health. That was, I think, pretty insightful. So, and again, of course, to the NINR for allowing such a discussion.
Dr. Fitzpatrick. Okay. Everyone needs to talk. I'm giving you a warning.
Yeah, I was going to say, I echo everything that's been said. I don't have too much to add. I completely agree with about the primary care focus, but I'm also a specialty care provider, and I think there's tremendous work that can be done there. Often we're in the position where we're getting the patients that the primary care specialist, they can't take care of them. and the numbers are overwhelming. We can't get them in to be seen. There's all kinds of bottlenecks and barriers. So I would say, yes, absolutely primary care, but there's a specialty care component too, particularly for the very, very ill.
Great. Thank you. Dr. Beckmeyer?
Yeah, you're putting the students on the.
I gave you a warning.
You did. I was glad I was last. A couple of things I'm musing with here is, we've talked a lot about nursing. This has bubbled up quite a few times, nursing education in general. And, it makes me wonder, well, what is NINR's role with nursing education in general? So I'd be just curious to hear what people think about that. In connection with that, it makes me think of when I used to teach undergrad community health nursing. I always had students read this essay that someone had written about what if nursing students were encouraged that their first job be in a community setting instead of, so often they're still told, I understand, from students that their first job ought to be in med surg, and that would kind of totally reframe how nurses think in general about nursing care. But again, it comes back to what is NINR's role around nursing education. And also I'm thinking too, I like what you brought up. I like the whole discussion. The whole discussion has been really powerful. But a takeaway to me was nicely framing, particularly what nursing contributions are to this work, and at all levels, like you bring up, and it's multi-level. We really do show up in these different spaces, including the community, but also in acute care. And what do we bring? We bring this clinical knowledge, this intimacy during life's most sentinel moments, and this really deep public trust, which I bring back again, is a burden and a responsibility and an obligation for us to use that in every way possible to have an impact on this, eliminating inequities. But those are, I would agree, those are really the three sort of unique, powerful things that we bring as nurse scientists and nurses, et cetera. So that's it.
Great.
Can I respond to
yes,
that?
Please.
And I don't know, maybe Shannon, maybe you should be responding about what can an NINR do about education. But I don't think we need to think about it that way. It's not necessarily what NINR's relationship is or is not to nursing education outside of education to become a nurse scientist, right? But it's the way I was thinking about it was more, this is the context where nurse scientists are in. And so much as some contexts facilitate the deep engagement and the work that needs to be done, it therefore influences the ability to conduct the science that is in the, new strategic plan. So without getting involved in nursing education directly, there will be a cascade effect to it. If there were ways to incentivize schools to construct themselves in ways that facilitate nurse scientists being out in the community, and most likely it sure could entail bringing students. I mean, ideally it should. It will have the spillover effects in that domain.
Can I say something to that? Because I have to say, NINR has had a very specific role, at least in my educational trajectory, because some previous vanguard leadership, especially when we were mapping the Human Genome Project, really saw fit to pull together the Summer Genetics Institute. And I'm an alumni of class 2003. And so there was this investment, this foresight of we need to retrofit workforce with the skills and tools that they need because science is adapting and changing. And we take responsibility for at least a cohort of these individuals so that we could get some of that spillover back at universities and institutions, because then you could develop curricula that you could make available to your students. And I think that kind of interesting community, funder, School of Nursing kind of partnership, that could be a whole other set of communities that we could bring together for an incubator activity to say, okay, we have a situation where we want to retrofit historically curricula that we've taught in terms of skills that we want, or competencies that we want nurses to be able to embody. And so therefore, where's the Venn diagram of all of our roles in that? And how can we create a play space for all of us to think about that in a way that can result in different decisions and change behavior in the future? Like that, to me, being able to host an incubator or an accelerator or some other kind of generative space that will allow for us to see the larger communities, if we all took ownership and responsibility of the future students, learners, scientists, whatever, and saw community members as the folks that we are primarily interested in bringing through that trajectory, so that we see people who use our services as our future workforce. Like that, in my mind, could be a really magical thing that could happen.
Great. Any other feedback? Well, I first want to thank all of our speakers and all of our council members for sharing your perspective. It's really important. I'm sorry for forcing some of you to share your experience or insights. And I think it's just critical, important question for NINR, sort of in guiding the next 20, 40 years of nursing science, and the critical role in supporting nursing scientists, be it pre-doctoral, postdoctoral scientists, junior, mid-career, senior. How can we keep this pipeline coming? And how can we think about being bold? Maybe part of being bold is implementing in a way that maybe when things are not working, that we should think about, like Ms. Harrington are saying, de-implementing or removing, some of those barriers, and continue to really think about nursing science within the context about, well, we can train nurses to be everyone, or we cannot train community health workers to be a nurse. So in these kind of innovative health and healthcare delivery models that nurses are going to lead, how can we also think about these professional and interprofessional teams with paraprofessionals in advancing nursing science? So really what I would like to end is that there is hope. And we really would like to see, I dream about a world where if we think that some strategy or we already have the evidence from this research, why can't every community adopt it? If there is a training that one school has been funded to create all these training, how can we make it easy and being adopted by every school of nursing that may not have the resources and the talent at the time to implement these, and so for everyone to have the opportunity to be educated and to be trained and really bring the best talent together to move the needle forward? What are the barriers, and how can we remove those barriers in translating these into all the School of Nursing and all of it, so we keep building up the science to move the field forward? So I'll end here and bring it back to Dr. Zek. Thank you.
Well, first, let me thank again Dr. Knipe and Dr. McLemore for joining us today and sharing with us, generating that great discussion. And Dr. Wang, thank you for leading us discussion and calling on people so I didn't have to. So thank you for that. We really appreciate everybody's, willingness to engage in this conversation, to help us think going forward, and just consider this the start of the dialogue in terms of where we need to go next in the next 40 years of the Institute. And again, going back to our North Star, right, thinking about how all of these efforts and all of these ideas fit together to move towards that North Star of health equity and all that needs to happen so that the lack of progress, the insufficient progress is so evident and so painful to see, that we can make a difference through our science. So again, thank you everyone for engaging in this conversation. So with that, guess what? It's break time. It's break time. So we will break until 2:45 and then we'll come back. We have a really exciting concept we're interested in your feedback on, and then we'll move into closed session. So thank you all very much. All right, welcome back. So we're going to move on to concepts. And as you know, in your role, advisory role to the NINR director, you are NINR's source of non-governmental advice on research directions and scientific priorities. NINR seeks counsel's advice for long-term planning at an early stage by presenting concepts for clearance. A concept is the earliest planning stage of an initiative before developing a funding opportunity or other activity. Any approved concept may or may not ultimately become a funding initiative based on a number of factors, including funds availability. So a summary of today's concept was made available in the electronic council book for your review in advance of the meeting. So next, I am pleased to welcome NINR Program Director and Branch Chief, Dr. Karen Kale. She'll present a concept on building capacity for community-partnered nursing research. Welcome.
Thank you, Dr. Zunk, and thank you to the council. I'm really excited to present this concept to you today. Next, please. So this concept has been developed by a team. Dr. Dara Blackman-Demner, Dr. Nadra Tyus, and I have been working on it for the last few months, and we're very excited because the concept, we think, addresses many of the things we've been discussing today. Next, please. So you've heard a great deal today about the continued challenges in achieving and experiencing health equity. We know that to achieve health equity for historically disadvantaged communities, social and structural factors that are underpinning those disparities need to be addressed. We also know that community engagement in the research process is critical to these efforts. And we know that community partnerships are very central to nursing education and service delivery. There are also challenges that sometimes prevent schools and colleges of nursing, especially those with limited prior NIH funding, to conduct this type of community-partnered, solutions-oriented research. And there's a need for support to facilitate research activities, which may include things like supporting investigator time, providing support for community partners, and building research staff and infrastructure. Next, please. As we've been hearing, community engagement throughout the research process is critical to ensure that the community's perspective, expertise, and priorities are well integrated. And when we're talking about throughout the research process, we very much mean from the very beginning of thinking of what are the challenges, identifying those research questions, planning solutions, planning implementation, evaluation, and dissemination. This partnership approach ensures alignment with community needs, priorities, and goals, and helps to build trust and facilitate long-term sustainability of health improving programs and practices. We aim to stimulate nursing science that's moving to the right on this continuum towards collaboration and shared leadership with the community. Next, please. Previous NINR-funded centers have been successful in supporting the development of nurse scientists and interdisciplinary research teams, as evidenced by increased numbers of publications and subsequent NIH grant awards. However, since 2014, only 15 schools and colleges of nursing of the 144 that are accredited and offering research doctorate degrees have had NINR-funded research centers. Many schools and colleges of nursing, however, do have educational and service collaborations within their communities, And we see this as an opportunity to leverage existing partnerships to conduct community-partnered, solutions-oriented research. We do know that schools and colleges of nursing that have had limited prior NIH funding may need some additional support to facilitate some of these research activities. Next, please. Therefore, the purpose of this initiative is to support the development of innovative research centers that will foster nursing-led programs of community-partnered research that aim to advance health equity by applying NINR's research lenses. This initiative would seek to leverage existing community relationships of schools and colleges of nursing and their faculty to provide a foundation for advancing community-partnered nursing research. A central feature of this initiative would be building capacity through these research centers in schools and colleges of nursing, with an emphasis on those that have limited prior NIH support. These centers would support planning for new research activities, for pilot studies that offer potential solutions, and that offer opportunity for developing teams and partnerships. A key feature would be to look at providing resources that could indeed free investigator time for research, pay for research support staff, and other key infrastructure. Finally, a goal of the program is to enhance the research capacity and provide opportunities for investigators to improve knowledge and skills in community-partnered research, which may increase their competitiveness for future NIH funding. Next, please. Some examples of objectives that might be included in the initiative are development of research centers that do propose these pilot research projects that would incorporate community priorities in the design, conduct, evaluation, and dissemination of the research. Another potential objective is stimulating studies that utilize the NINR research lenses and focus on developing solutions to community challenges. We know that promoting development of interdisciplinary teams is critical, and these issues that communities face and figuring out ways to build or adapt solutions as well as testing them are very complex. So this would benefit from the expertise of scientists of several disciplines. In addition, nurse scientists can benefit from mentors in disciplines other than nursing to broaden their knowledge and their perspectives. One objective could be providing support for developing nurse-led interdisciplinary teams to conduct this research with community partners. Again, by building these teams, it gives them a history of successful teamwork that they can build on for future funding opportunities and future research endeavors. Another potential objective would be supporting developmental activities for investigators at all levels of experience and for their community partners to improve their knowledge and to foster partnerships between the academic and community groups. Next, please. So with this, I thank you for your time and attention, and I'm really looking forward to the comments and discussion.
Thank you, Dr. Kale, and Dr. Stone. We'll let you start us off.
Thank you so much. I'm really excited about this concept. I think we've talked about in council a lot about the same schools, you know, me being at one of them, lucky us, you know, that continue to get research funding. But it's, we need to, if we're really going to make meaningful change for people, we need to be in for marginalized or minority, racial and ethnic minority populations. We need to be in schools of nursing that are serving that. And I mean, you know, and we need to also diversify our nursing scientific workforce to really do that. And so I think this is really a way to get at that. So it very much excited me. I think one of the things that, you know, and it meets other NIH goals. It's very synergistic with the idea, you know, the institutional development awards, you know, that are looking at HBUs or institutions in certain states that don't have a lot of NIH funding. I think this could be really translational research. I think some of the things that is very important is that in this is that the you mentioned, Dr. Keel, that it has a potential to enhance knowledge and skills and increase the competitiveness for future NIH. I think that is where you really want to be. I mean, you can't ensure future NIH funding, obviously, but having that, ensuring that mentorship, whether it's within the institution or, outside, partnering with the research intensive institution and another school of nursing, but ensuring and how to ensure that. I think that's really important because that's what's going to make this investment sustainable in that community and elevate those people that are doing this. And I think it's very important. And I love the idea that it's interdisciplinary teams led by nurse scientists. That's all I have to say. I like it. We got 15 more minutes to discuss this. Anybody else have any ideas? I think it's terrific. Yeah, go ahead.
So I really loved the concept, and I was struck by how thoughtful and deliberate I sensed as you were going through the slides that the three folks that worked on it, there was a lot of thought that went into each of those bullets. It's very clear from the way it was presented and reading the actual words. And so thank you for that. Just two things. One, that may or may not fit into today's discussion, but the 15 schools and this sort of, I'll call it a conundrum that we're in nursing. How do we think about maybe having some discussion at some point about sort of what are the underlying reasons for that? What's really happening there? And what are places where schools should be collectively trying to respond? How that relates to the concept and the creation of what I think would be an invaluable infrastructure. Is there such a notion of reciprocal sort of rigor and impact, ensuring that the schools that are not funded currently, but that have great proximity to the communities that they work with through their partnerships, that their knowledge is transferred to the schools that maybe are the 15 that are in fact continuously getting funding, and vice versa? Is there a kind of scientific rigor that, whether we agree with it or not, that is sort of the currency of the way that scholarship and research and evidence is received? Is there some way to bring that together to ensure that the end of this amazing initiative, assuming that it were to go forward, that it wouldn't be deemed based on our current criteria as somehow not being strong evidence? And just throwing that out there, I know those are unpopular thoughts, but I wonder if there's a way to kind of make more wins here in terms of how it gets implemented.
I think that's really, I think that ensuring that the enhancement of the skills is really important. One way that you're suggesting, Vincent, is that there's a partnership or a consortium of the schools that get the funding and the schools that have the funding, so that there could be shared knowledge across. Shared knowledge on what's needed, shared knowledge on how to do the research and write the grants once you get to that point, or even maybe shared knowledge on how to write the grants in the beginning to get the funding. I think, and these schools are also already have PhD programs, and often they have PhD programs that they're being taught by nurses that have never really have had funded research. Maybe they've had some, but they haven't. So what are they teaching? So how that's done, I think, could be thoughtful. I think there's different mechanisms, and I think that NINR has probably thought about some of those, but I think that's because you want this to really elevate. And that's got to be part of it, in my mind.
So just one really quick comment. I just want to reiterate that I reference reciprocal.
Yeah.
And that it really is also that the schools that are outside of the 15, there's something essential that those institutions can teach the 15 and others.
Oh, yeah, no, absolutely.
I just wanted to make sure that was in the notes because I'm afraid that it will go in the wrong direction. So just want to put that. Yeah.
Yes, please.
Yeah, thank you. I also really like the concept, and I think it's you all have given a lot of thoughts into just balancing different components, like schools that have been funded with the PhD program versus schools who have limited funding, and also I'm thinking about like what are we, what's the impact this concept can generate through funding. So when I think ahead, I think some of the things that we may want to consider is that if we're truly valuing is how this concept will bring the impact to the community, I think some of the heavily funded institutions, if they are bringing major impact to the communities that they serve in that community partnership, I don't think they should be disadvantaged just because they have been historically having funding. I also think that for those who do not currently have major fundings, or even those who may not have a PhD program or have a combined venture, how do we help them? Because they may be the people who will never become your applicants. What's the kind of unintended consequences this may create? So I think balancing the different sides, but also kind of the different sides of the different sides. How can we kind of leverage this concept to generate the impact and sort of the North Star of an NINR for the health equity? It's sometimes maybe are we targeting the schools? Are we targeting the pipeline of generating neuroscientists? Are we focusing on the impact of the community, the populations? And maybe we should look at whoever can leverage all of them and can marry all of it for us to kind of bring the impact, but thinking about with that equity lens when we look at all the different schools, different pipelines and different communities that this concept can bring.
Thank you very much for those comments. I was particularly struck by what you said about, and it's very true, there are some schools and colleges of nursing that have great impact in their community. There are also some very well-funded schools and colleges of nursing where community engaged research has not been a priority, is a new priority that may also benefit. So we're still very much at the concept stage. So nothing is written in stone at this point, but it's very helpful to hear those comments.
One of the pieces of advice I would offer is it's probably going to be helpful to think about what the scored criterion would be for these applications. So there's impact to the community itself. I mean, maybe it's a desperate need and a fabulous idea. There's also, building the next generation that's a scored criterion, independent of whether the schools have been funded historically or not. So I really think it's getting at what that deliverable is that you want to achieve and making sure that the scoring reflects that. And it's probably some composite and that will have to be communicated to the reviewers. And so.
Thank you very much.
I think there's precedent for like this in different NIH initiatives. I think in all of us there was precedent for things like this, where this is to get people involved that have not been involved before, and I like that idea. I really do. And like in R25, it's there was people that came and said, "Oh, we should be doing this." This R25 for all of us. And it's like, no, that's not what it's about. It's about getting people involved in the research that haven't been involved in the research before, in that research. and that idea of trying to get them involved. The thing is that you just want to do it well so they can stay involved. It's not a one-offer, you know, Dr. Fitzpatrick, I think your idea of how the scores, you know, ensuring that the proposals are reviewed and scored to what the criterion that you want would be important, because it's different. It's not the same old study section. And that idea of sustainability of it and how that they're going to learn. But heck, we got a lot of nursing schools out there that don't have any NIH funding or any other type of funding, and they are putting out PhDs or DNSs, and that, you know, and they're just not getting the same sort of level of education about being a nurse scientist as I would want them to.
I mean, I think the resources for writing grants tend to fall on the CTSA funded institutions, which are the people you are not talking about here. And so, you know, the webinars and things you'll have to do to even instruct these schools to apply it's not small. They don't have CTSAs.
You are absolutely correct. And I will say we do have quite a bit of experience with some of the initiatives we've had in the last couple of years that aren't looking for your usual cast of characters when it comes to applying. So we absolutely would take all of what we've learned into account in trying to set up people to be successful, even in terms of being able to write an application that meets all the criteria.
Just to pony onto some of what was said here too, I'm thinking, you know, I totally agree. I was thinking the same thing. It would take a lot of effort to get people on board even thinking about applying, and then how to, et cetera. But I'm excited about the opportunity to lift up some of these schools that already do really good work with the tribes in their communities. I'm thinking of a colleague at Montana State University and another that was in the School of Nursing in the Dakotas, and that does a lot of amazing nurse work as nurse faculty or researchers with in tribal communities. And so what we're talking about here could be a way to reach some of these populations in new and more effective ways in the rural areas and with indigenous communities, et cetera. And, you know, I love the idea. It's going to take a different way of thinking and reaching folks and help and giving them what they need to get the resources, not necessarily to do some of the work, because they're going to know how to do that better than we are, right? But it's exciting. The idea is exciting, and it goes back to what you were talking about, Vincent, in terms of reaching some of these populations, working with these populations in different ways. I like it.
You mentioned you actually got to a comment that I was interested in. What is happening now in terms of leadership development of those who have been funded? I'm trying to think of an institution that is not used to having this type of funding. Then they get this type of funding, and it's very tempting to use it for other purposes. And so, I mean, especially now, I mean, we have more money than our institution. They see our budgets. And so, yeah, what kind of training is being done? What kind of leadership development?
So I need a little bit of clarification, because I heard a couple of questions in there. One being, what type of oversight is there to make sure that people actually use funding for what they're supposed to use it for? And
not so much that question. It's more helping the individual lead the project or lead the effort within their own institution.
So what I can say is what's been done in previous efforts in NINR funded centers And there have been some really well-developed ways of doing this. Now, I'm not saying that we would do all of these or that this necessarily would be part of it. It's just an example of what has been done. One of the things that was done in the past was that there was an annual meeting where all of the center directors came together. They learned from one another. Over time, that got expanded so that the investigators, the pilot investigators, would present their studies, would learn from people from other centers, would learn from their colleagues, would find opportunities to collaborate there. In the past, centers have all had scientific advisory councils, and many of them did have community advisory groups or councils. But those scientific and operational advisory councils were very important to learn from people who had done other similar types of projects. They might not have had an NINR funded center. They might have had some other type of center, but bringing in that expertise from the very beginning so that they have a group to go to and say, hey, we don't know how to do this. You know, we proposed it. It sounds really good, but now how do we operationalize that?
And just to further expand on that, the experience I've had in those types of meetings are really focused on the science, which is great, about implementation and whatnot. It's less so about how do I manage this center in my institution. So just encouraging you to have a little bit more discussion about that.
Yes, thank you. I can tell you that was certainly something that we saw over time, and in the more recent iterations of centers, there was a lot more built in looking at evaluation criteria and how you do some of those operational pieces. But you're absolutely correct. That is something that most definitely needs attention.
I too just want to echo how excited I was to hear about the concept, and I support what you've laid out. There are two things I wanted to raise coming from an HBCU myself. We're always thinking about the power dynamics between our HBCUs and other institutions, and for, I think, legitimate reasons, historical mistreatment from maybe other institutions. That's something to keep in mind as you're building this out, and then the power dynamics between these institutions. So I applaud the effort to talk about reciprocity and reciprocal and whatnot, but those things need to be very carefully thought about to make sure that HBCUs, tribal colleges, and others believe that they are running this, because a lot of times folks say, oh no, we'll come and help you. We don't need help. We know health equity research, but what we need are the resources. Right. And we want to work with other folks. So I think that needs to be considered as you're.
It's a fantastic point. And absolutely, we have had many, many discussions on how different ways we may be able to operationalize this. As all of you have brought to light, there are many. This is not an easy endeavor. It's a complex endeavor, and we're very well aware of that. And we appreciate the points that you brought forward, just because it helps cement in our mind some of the things that we have already discussed, but need to go back and revisit. As I said, it's a complex endeavor, but it's one that we think is very worthwhile.
Hello. Yes. Hello. Can you hear me okay?
Yes.
Hello.
Yes. Yes.
Hey, thank you. Great. Good morning. Sorry. More afternoon. Sorry. I am in Tokyo at the moment, so it's a little bit of a time shift for me coming to you from your future. But I just wanted to say this is a tremendous effort, and I'd like to proffer, if I could, an example that the DoD employs. I know many of you have probably heard of the Tri-Service Nursing Research Program, which is a grant funding agency that supports nurse-led science. And that's one of the things we're doing is we're out in the field this month spreading word about that program and doing some EBP courses. 2 points I wanted to address is one, ensuring that the funds for a particular research project or used for that project, of course, would be a function of the call and negotiating the award. But one of the things the Tri-Service Nursing Research Program does to support solid competitive applications is that we offer a lot of training with that. So you may consider, as a function of having these awards and a call to historically disadvantaged institutions, is offering a training program. One of the things that Tri-Service offers is a grant writing, we call it Grant Camp, right? And it is a program it's a week-long mentored program where we have experienced nurse scientists historically have interacted with TSNRP come in, and they one-on-one mentor individuals on development of a solid grant application, all of the things that need to go in that. So it's a little bit of didactic, a little bit of we'll talk to the group, and a little bit of one-on-one mentoring for them to help develop a solid application. And then those applications ostensibly are competed in the next round of funding. Another thing that is important, particularly when you talk about new grantees, we have a post-award course that is used for particularly first-time applicants who are awarded funding, come to this. It's a requisite of the funding, and they come to the post-award training, and they learn how to do all of their regular reports and to manage the grant. And another component that we have, of course, is a resource center where we can bring other expertise, statisticians, and things that other military treatment facilities may lack, that nurses who are wanting to do some science can get after it with some of these resources. So I think it's imminently doable. I don't know how it affects the ultimate amount of the award. The concept is fabulous, and I think that you can employ some of those methods to help extend that. Thank you.
So Daniel, I'm going to respond to your comment. So I don't disagree with you. I think the thing that I was trying to articulate that I think is very complicated. So in terms of your example, I in no way am saying that institutions that, for reasons that are complex, who have not gotten funding, are not well prepared to actually do that research. What I heard at the start of this conversation is that there are 144 schools of nursing, not HBCUs or HSIs, but schools of nursing. The vast majority of those schools are actually not schools that are specifically targeting communities of color, right? They're the schools of nursing. And in nursing, we've had some challenges that we as a profession need to talk about. We have a shortage of PhDs that are going into the profession. We have many senior nurse scientists retiring. We have a lot of, and again, these are my thoughts, and so I take responsibility for them. We have a lot of emphasis on trying to sort of walk a fine line between ensuring that we're being flexible in how we deliver our PhD education, and also trying to maintain rigor. And that tension is palpable. Review committees, it's not unusual for comments to come up, well, this is too methodologically rigorous or too ambitious or blah, blah, blah. And so I think that what I'm really getting at is that we need to understand, why are the majority of the schools of nursing not getting funded? And we've got some work to do, and I think that there's a great opportunity. I love the concept. I think it's not the case that I'm suggesting some of what I thought you might have been saying. I'm not certain, but it's not about schools that represent underserved and ethnically and racially diverse populations that have not gotten funding for reasons that are well established. It's not about that. There's a larger problem. So I just wanted to point that out because I think we got to work on that.
Well, thank you all very much for your comments. You've given us a great deal to add to our list of things to address. This is exactly why we want to bring this to you, though. We'd much rather think about these things now as we're moving forward than later. So thank you, and thank you very much for your enthusiasm for the concept.